very quick to talk about this equity topic on the access pathway of cancer care, especially in rural communities. I did my fellowship in Canada on health service research, and I'm very passionate about equity, access, and affordability and costing of cancer, especially in low and middle income countries. So a bit of a background: Kenya is really making a big stride in decentralizing cancer care. Part of that has been shown in the establishment of 3 regional cancer centers outside Nairobi. And before, people used to walk, used to travel all the way to the capital, which is quite far for some patients, covering thousands of kilometers to seek care in Nairobi, the capital, specifically for radiotherapy. But in the last 5 years, the great news is that 3 regional cancer centers, fully fledged, with chemotherapy, radiotherapy, and oncologists and the whole workforce of cancer care deployed. So averting a lot of traffic off Nairobi. So I thought I will share with those who are not aware how impactful this journey has been for Kenya and for cancer patients. Why decentralize cancer care? As you see, the incidence of cancer care in Kenya is annually 42,000 patients. This data might not be even very commensurate with the real picture on the ground, because we do not have many cancer registries. This is the Globocon data that feeds to the global websites. But it's based of only 2 cancer registries in Kenya. So I even believe the numbers are even higher than that. And 50% of that, close to 50%, 27,000 patients die every year, either through late stage presentation or poor access to cancer care, or due to other avoidable circumstances. So bringing care closer to patients really averts not only lost life, but also cost of referrals, and strengthens equity. As you know, cancer care equity is a big thing, and many people should not really die of cancer based on where they live or how they look or what they believe. So I think this concept of cancer care equity is really alive in the Kenyan context. Okay. So Kenya has really done all these policies in commensurate with the national guidelines and international partnerships. The cancer control strategy in Kenya is based on this access and decentralization of care. And that's in line with international and IEA protocols, or WHO, especially for radiotherapy access. Similarly, for that to happen, there need to be a scale-up of infrastructure, cancer infrastructure, including machines and workforce development. And also closer home to Kenya, there is this really excitement about enrolling universal health coverage that will really be part of cancer care in terms of reaching the unreached by use of the payment for communicable diseases such as cancer. So earlier treatment save lives, as I've said in my background. Kenya radiotherapy expansion journey is actually all the way from 2018. Referrals have been every other year been introducing to Nairobi. And in fact, now the picture you see is there are more referrals to the regional cancer centers than from the community county hospitals. Part of them is Nakuru Cancer Center in central part of Kenya, the Garissa, where I work, in northern part of Kenya, and then the coastal region, which is the Mombasa Cancer Center. And I'm also happy to report that there are actually more than 10 more cancer centers, regional cancer centers coming up, especially in Kisii County, in the Lake region of Kenya, the Nyanza Province, Homa Bay counties, Kisumu, Meru, central Kenya. All these are coming up. Yes, so I think I've just mentioned this before. This is just a snapshot of what the current services of cancer care in Kenya is in terms of the public and the private hospitals. It's sometimes sad to see that there are more efficiency in the private hospitals, but at a huge cost, which really should not be the case. So some of the centers that offer radiotherapy, chemo is not the focus here of my talk, it's the radiotherapy access, because there's several low-tier hospitals across the country country that do offer actually chemotherapy. But my point of discussion is really around radiotherapy access, which really is used in more than 50% of cancer treatment. So in the private, you know of Aga Khan, MP Shah, Nairobi Hospital, Nairobi West, Ruai Family, Texas Cancer Center. And you'll be surprised, all these private hospitals are situated in Nairobi. So it has nothing to do with access to the people who really need it, even though it serves Kenyan and Nairobi population. On the other hand, public institutions with radiotherapy include major university-affiliated hospitals, Kenyatta National Hospital, KU, which is Kenyatta University Teaching and Referral Hospital, Moi University, now the new kids on the block, Garissa, Mombasa, and Nakuru. So fairly equal distribution, but I think we need more people in the public sector for ease of accessibility and cost. Because if I was to give you a simple example, one radiotherapy session in these private hospitals cost, for a good technology of radiotherapy, 14,000 Kenyan shilling. That's quick math. I don't know how many dollars that is. That 14,000? Yeah, almost $120, I don't know, around that for one session. Where in the other developed world, this is like as low as $25. But in Garissa and Nakuru, okay, let me speak for Garissa because that's where I lead. One session of radiotherapy is barely 3,600 Kenyan shilling compared to 14,000. That's like a drop of third of the price. So you're looking at around maybe $25 a session in Garissa Regional Cancer Center. And I believe the numbers are almost the same in Mombasa and Nakuru. So part of the impact, actually, this is part of unpublished data that I'm working on. I did a feasibility study on impact of accessibility of radiotherapy to regional cancer centers. I wasn't interested in Nairobi, so I talked to my colleagues in Nairobi, in Mombasa, Garissa, and Nakuru to put together, few parameters to show that cancer care access, specifically radiotherapy, is improving lives. And you see the top cancers in Garissa is head and neck cancers and breast and prostate. Similarly, in Nakuru, and this data is actually available now in many of the hospitals, is a bit of change of pattern. You see in Nakuru, you see a lot of breast, prostate, cervix, esophagus, and colorectal. But in Garissa, you see a lot of head and neck cancers. Again, this wouldn't have been known if we did not have this center and if research was not initiated. Okay. Yeah, and this is good news. Look at that. In the treatment completion rate of actually radiotherapy is improving. Garissa, also, everything is above 80%. And this is important because for someone to get treatment and to complete specifically, it means really specifically for radiotherapy, it's a tough treatment. But the fact that people are actually completing treatment really will affect the survival and the care to the community. And the disease control, of course. Similarly, that definitely goes without saying, referrals have been averted. If you look on the far left, the number of patients treated before radiotherapy in Garissa was barely 0. And right now, in 2.5 years, we've treated more than 500 patients. And if you look at Mombasa, they've treated close to 2,000 patients. That's actually a good number for radiotherapy. And in Nakuru, coming close to around 1,300. And that is, compared to on the right side, the referrals averted, positive deflection showing no patient retained regionally, and negative deflection showing few external referrals. So Mombasa had a bit of referrals to Garissa actually because of machine breakdown, but I think these numbers continue to grow as we continue looking closely on the impact. Reliability of these machines in the regional cancer centers have not been without challenges. For example, in Garissa, which had more issues than the other regional cancer centers, there was actually a time when the breakdown was almost a whole year. And it was really sad, and that's because of poor service level agreement with the vendor, but this has really been solved now and everything is back to normal. And machine breakdown days for Mombasa and Nakuru as well has been a bit lower compared to Garissa. So, but now because of the SLA, service level agreement, Nakuru has built a new second machine in Nakuru, which is also a regional cancer center. And in Garissa, we have a bunker ready for another machine, which will really improve more access. I think reliability is going to really improve compared to historically single machine, single center issues where when one breaks, we have no any backup. So I think this is going to really improve. And then you see, again, in terms of health system effects, definitely treating patients closer to home leads to a domino effect, not only for the individual patient and the family, but even to health systems and cost aversion. So you see, you travel costs, which are indirect costs, will be reduced. Low cost income, for example, in Garissa, a single radiotherapy session is only 25. Public transport you don't need, and fewer escort trips. And even people come into Nairobi and they've never been to Nairobi, so they have to look for somewhere to stay, hotel, food, transportation. Radiotherapy, it's a daily treatment. Can you imagine someone coming all the way from Garissa to Nairobi in a private hospital, which is 14,000 a day of a session for 28 sessions of radiotherapy, and daily transport of Monday to Friday. Radiotherapy is not like chemo where you're given once a week or 3 times a week. 3 weekly. So radiotherapy is a daily cost and it's really cost intensive. And if it's really going closer to where the person lives, this is really actually game changer. Social Health Security and Authority, despite its own drama and whatever you guys think about, actually has been really helping people in terms of oncology package. And this is, I'm not speaking for SHA, but I see how it really helps patients in the local hospitals. At least for chemotherapy, it pays all chemotherapy sessions. Now they are even, and radiotherapy, it pays around 20 out of 28 sessions. So it's not that bad. But again, the cost is even much more relevant to local cancer centers than when you use SHA in private hospital. It's like a drop of ocean. When you go to use your card in private hospital, it's 2 sessions, because one of them is 14,000. In 10 sessions, you have depleted your cover. But in Garissa Regional Cancer Center, we've capped the radiotherapy SHA rates based on we charge 3,600 only, and that's actually a SHA rate. So someone can actually use their card to finish completely radiotherapy. And I hope the case is the same in other regional cancer centers. I think SHA is also trying to think about expanding the package from 550K a year to maybe to more. We'll see what they do about that. So impact assessment, I think I've talked about this. In Garissa now, patient treated are close to 500. Mombasa, this is I think treatment locally after radiotherapy initiation right now is 300, close to 400. Before it was 0, all referred to Nairobi. So that means referral volume has grown, reduced by 30% to Garissa. And completion rate right now in Garissa is 93%, and patient can now be accommodated within Garissa. And we are working on a very master plan of actually building hostels for patients who are not from local communities, so that they can stay closer to the hospital and the center. We've measured, how did we measure this impact? This is part of the unpublished study we're working on. New referrals averted equals to new local radiotherapy patient that start on time, the percentage of that went previously to Nairobi. So this is a bit of health economics, mathematics. Earlier treatment equals to median diagnosis to median time of radiotherapy initiations was very low compared to when the centers were not there and they never went. So the cost rescued in terms of the delta look like travel plus accommodation plus lost income per cost has actually been reduced significantly. And reliability is a problem as of now, but we're really working on making the time, the downtime of the radiotherapy machine to be better than before. Mombasa, same thing. They treat 40 to 60 patients per day. This is unheard of. Referrals to distance centers are reduced to by 90%. Radiotherapy completion rate in Mombasa is actually very good, is 85. And their median treatment, diagnosis to treatment time used to be, it's around 60 days. I know that's a lot, but that is nothing better than completely, when before they never used to get that. And they serve a community of distance from 300 kilometers. That's a lot that come to Mombasa, because that's near to them than going to Nairobi, which will probably be another 300 kilometers. So operational capacity and staffing challenges right now in Garissa is we're only 4 radiation oncologists, there are 2 medical physicists, 5 nurses. There's a lot of gaps in social work, patient navigation, which are really working on, and a bit of the machine breakdown, so biomedical engineers are very few. Mombasa, they complain of the same thing according to the study, the survey that I sent to them. Radiation oncologists, very few, medical physicists, same number of radiation therapists. So finally, the impact here really is in terms of the metric of measure for this decentralized care in terms of radiotherapy. In Garissa, it's operational right now. Mombasa, same thing, and Nakuru. Patients treated per year, look at those numbers. I know Mombasa, Nakuru and Mombasa are more, but you can't actually downplay that number of 397 in Garissa, where before in 5 years ago, we never ever used to think of any cancer treatment. So that's really good. And we're getting more referrals. So this is a preliminary data, and in 3 years, actually, we might see that number going rapidly. Radiotherapy completion rate, fairly okay, above 80% according to the international guidelines for radiotherapy completion rate. Machine downtime, Garissa had issues, but no longer, because now we have signed our service level agreement with the vendor, and referral shifts have been been low, and top referring counties specifically for Garissa is all the neighboring Kilifi, Kwale, for Mombasa, and Baringo, Bomet are the topmost referral pathways. So next step, I think we need to protect what we have and enhance it so that we don't fall off the wagon of success. Complete the care of cancer care patients, especially social part, navigation, consumables, shortages, and all that, and leverage on SHA, because it's very costly to treat cancer. Cancer is an expensive diagnosis, and many people do not have health insurance. So I really urge people to really take up SHA. Despite its challenges, like I told you, it does work and it's better than nothing. I think I'll stop there, and let's remember that cancer care disparity should not be defined where you live or who you are. Thank you so much.
Thank you, Dr. Omar. So next we will invite Stephanie Hash to tell us about her project, and we will have questions afterwards. So just write your questions down, and then you'll ask them later. Yes, and she'll be speaking about cancer health literacy, which I also think is an interesting topic. So I'll let her pick it up from there.
Thank you very much. Good morning. I hope you're all well and you're ready for this wonderful day with a lot of input. I'm delighted to be here and to speak on a project that ICRF has implemented during the last 2 years together with the University of Freiburg and other collaborating partners. We focused on how can we improve cancer health literacy by using cancer survivor stories. What do I want to achieve within the few minutes that have been given to me? First, I would like to sketch out a problem and also expand on the opportunities that we have here in Kenya. Then I quickly want to describe the methods, present selected findings, and then distill some lessons learned from research with cancer patients. And maybe we can have some discussions around that later on. So let's get started. We all heard a lot about the incidence rise of cancer all across sub-Saharan Africa, and it put a lot of burden on the healthcare systems, but also the society. The speaker that spoke before me, Omar, already expanded on that. But there's also another part to it. It's the part of the cancer survivor, the cancer patient, and their family. And when we look into literature, we see that they have a lot of struggles regarding treatment, managing their daily lives, social impact, the impact on their faith and their finances. When we look at along the cancer care continuum, then we see that we need to have some improvement in terms of healthcare provision, such as availability, accessibility, affordability, and equality. But then we also need to look at those that we serve, the public, the patients. Do they actually have the ability to engage with the healthcare system? Do they understand the information that is provided? Can they cope with it? And can they make decisions for themselves? So when we looked at all the different phases of the cancer care continuum, people need the knowledge, the motivation, and also the competence actually to find, understand, appraise, and apply cancer-related information that they encounter it all the time. Research has shown that if we improve cancer health literacy, then cancer patients can cope better with the challenges. It fosters preventive cancer behavior. It reduces depression, reduces risk factors, lower treatment costs, and also improves quality of life. And I think all of us can agree that's what we want to achieve. So cancer health literacy is improved through cancer education. When we look at what is already happening in Kenya, we know that a lot of healthcare professionals offer some information. There are flyers, brochures, there's TV and radio, and specifically this month, we hear a lot about cancer because it's a Cancer Awareness Month for breast cancer. There are also social support groups, and for sure, there's the internet. So there are offers available for cancer patients to inform themselves about what they need to know. However, when we look at all these different offers, they are often just one point in time. They are often located in the cities. They are often not reaching those who need it. And people often can't go back. So if there's a cancer survivor speaking on TV, you can't go back and listen to that person again. So we were looking at, can we provide an educational offer that is timely, everywhere available, appealing, context-sensitive, culture respectful, informational, engaging, and inspiring. We reflected on what is already there. Are there other solutions that we can harness? And for Kenya, we can definitely harness the one opportunity such as digitalization, because at that point in time, apparently 72.6% have a smartphone in all of Kenya, which is quite high. And also the other opportunities using narratives in order to inspire people to expand their health literacy. And the narratives are actually also recommended by the WHO to be included in addition to evidence-based medicine. So knowing all that, we looked at what is already available. And in some countries, cancer patient experiences are already used, such as here up there in Europe, but also in Kenya, cancer patient experiences are displayed by some organizations or sometimes also on TV. We know that narratives can actually facilitate information processes. They allow people to have the words and they can stimulate conversations on the topic. They also help people to navigate their emotions and improve their motivation to change. They are transformative in the behavioral aspect, and they can deal with existential questions such as, what is the purpose for me to have cancer and what can I learn from it, and how can I reconstruct my own personal identity? So knowing all that, we thought of how can we use, what is the potential of narratives in Kenya, and can we use them in order to foster cancer health literacy here? We applied for a grant and we were lucky to get it. And so during the last 2 years, we focused on that. And we had different phases in the entire cancer health literacy project. First, we did, as always, a thorough review of cancer education and cancer literacy in Kenya, and we also analyzed policies. Then we conducted a lot of key informant interviews in order to really understand what are the advantages, what are the disadvantages of using narratives here in Kenya in that specific context. Next, we developed an intervention by interviewing more than 40 cancer patients who recorded and reported their story of how they were diagnosed with cancer and what helped them to live with it. Finally, we conducted a pilot study. There's a lot that I could report on all these different aspects, but because we have other people speaking on other aspects, I would like to focus and narrow down on the last two, such as the intervention and also the feasibility study that we conducted. So here's just a snapshot of the 40 cancer patients that we interviewed. We started with breast and prostate cancer patients because they are the, at least widely known, most common cancer types in Kenya. We had more breast cancer patients who were more willing to share their story than prostate cancer patients, but we managed to have cancer patients from a variety of different ages, ethnic communities, counties, villages, education and economic backgrounds. And we had very young cancer patients and very old cancer patients all shared their stories so that people could relate to them. Then we created a website, and it's called My Shana Cancer. You can see it here, and there's also the QR code that you can go to anytime if you want. Here, we do have videos available in Swahili and English, and also audio recordings. Moreover, we did not only narrow down on just the entire story, we also focused on if someone is interested in learning more about chemotherapy, let this person go to a place and they can listen to how people experience chemotherapy and what helped them to live with chemotherapy here in Kenya. There are lots of videos that you can watch. I only put one in here. You can just go to the website. I'm not going to play it. Lastly, after we've set up everything, we thought, now we have that website. Now we want to know, is it actually appealing and effective? So we wanted to find a questionnaire that we can use for the context here in Kenya. And when we searched thoroughly what questionnaires are available, we realized many of them are far too long. They have more than 30 items just for the health literacy, and cancer patients are already very stressed. We can't overburden them with tedious, long questionnaires. Most of the questionnaires available only look at the clinical side, but our cancer patients, they shared so much about the clinical, but also the social, their spiritual, and all the other aspects of their lives. So we thought this is not enough to only focus on the clinical side. Many of them only ask for knowledge. Do you know how to do A, B, C, and D? But knowledge doesn't equal using the knowledge and being able to apply the information. So we excluded those. Many of them only focused on prevention. We were interested in treatment. Others had really tedious translation processes, and others were simply insensitive to the situation in Kenya. So what we finally did was, we need to develop our own questionnaire based on the evidence that we had. And we were very, very lucky because we had these 40 narratives of our cancer patients. And just to give you an idea, the length of these biographical interviews were usually between 1 hour and 1 hour 30 minutes. So there's a lot of information that we gathered. And what we simply did was we searched for any kind of information that they said, we need information to do A, Y, Z. So we created an item pool based on what the cancer patients themselves described where they needed information. Then, after we generated this item pool derived from our narratives, we conducted a Delphi process, reviewed it with stakeholders, and asked them to evaluate how relevant it is, what is missing, whether we need to reframe it. And finally, we finalized a questionnaire that had 26 items and translated the questionnaire from English to Swahili and also tested the questionnaire. The questionnaire that we developed for cancer health literacy in Kenya has 4 components. It looks at functional health literacy, where it's more about understanding cancer-related issues, terminology, find healthcare services, so more basic competences. Then also more interactive competences, where it's more about inform your family about it, ask for emotional support, discuss how other people can support you. Then we had an interactive component, interaction with the healthcare workers. So ask the doctor question, inform about side effects, and use the information in order to make decisions in the healthcare sector. Finally, we also had a critical cancer health literacy, which is more about explaining, appraising, reasoning. So explaining the importance of checkups, counter myths and misconceptions, and also use the information to accept the disease and live with it. After we've done all that, we conducted a small feasibility study. Initially, we thought it might be small and we might only have 200 cancer patients. But you will see in a second, there were lots of cancer patients who were really willing to contribute. But when we set up this study, the cancer survivors that we closely collaborated with said, do not only inform us cancer patients, please reach out to the healthcare professionals. They need to know what we are actually going through. And so they encouraged us to also include nursing and medical students so that they get a holistic understanding of what it means to live with cancer, so they also can show more empathy when dealing with cancer patients within the restricted work conditions they have. So we had two different parts of the feasibility study. The first target group, our cancer patients, we first did a study and sent it out the first time, an online questionnaire, and we had more than 1,200 responses, which was quite impressive within 4 days. Cancer survivors, never underestimate them. They are really, really eager to do what they are and support initiatives that they find are important. So we could conduct this first-time study, and there we saw that when we look at 1 till 4, 1 is that people answered questions that it's very, very difficult to perform this task. 4 is it was very, very easy for them to perform the task. And so you see the majority of responses are below 2.5, which means almost all activity, regardless of whether it's in the functional part, in the interactive part, or in the critical part, are considered as difficult or very difficult to perform. We need to have that in mind when we deal with cancer patients. Then we allowed the cancer patients to interact with My China Cancer website, and then we asked them to fill in the questionnaire again. And here you can see an improvement for both men and women in all the scales, and a significant improvement. Moreover, we also conducted the interviews with the same study with nursing and medical students, and some of the findings were quite astonishing. We asked the nursing and medical students also to explain whether they have ever had contact to any cancer patients. And the nursing students, 60% said they've never had contact at all with any cancer patient. And for the medical student, it was 75%. And there were even medical students who reported that they shied away from the topic of cancer because they are afraid that they can't deal with it, and then they are in hospital and they have a cancer patient and they are not prepared to interact with that cancer patient because they are afraid that cancer is a death sentence and no one talks about it, so they've never engaged with any information about it. So we also invited them to participate in a pre-post test study, and here we can also see that cancer health literacy improved for the nursing students. For the medical student, it was quite interesting. They expected that cancer health literacy is already higher among cancer patients, and then when they engaged with lots of the videos, they realized it's actually very difficult for most of the cancer patients to perform these tasks and all the burdens they encountered. We also asked the medical students and the nursing students whether interacting with that website helped them in any way to better understand what cancer patients go through, and all of them reported that it helped them very much, for us very much. It helped them to better understand the barriers, they can better empathize with the cancer patients, and it also helps them more to perform person-centered care. So when we reflect, there's much more to report, but I wanted more to guide us into a reflection part. When we conduct research with cancer patients or cancer survivors, we've learned a few lessons. First, as always, when we conduct research, it's necessary that we follow the ethical principles. Without doubt, I don't need to expand on that. But then we definitely need to have a collaboration. It's about with and not about, and not reporting on. Because the cancer survivors that we closely collaborated with, they gave us a lot of very important insights on how to change it, on what to focus on, and what is actually cancer health literacy for them. Without them, ours would have looked very functional, very clinical, but they have given us the real insights that matter to them. Moreover, it also requires a certain flexibility. Some of the interviews we couldn't conduct because the cancer patients needed to go back to hospital. There were other incidences that were coming up. So be ready for changes that can happen. Moreover, the perspective of a cancer patient is not a single cancer patient. We always need to look at them in a family context and moreover also in a community context. We wanted to collaborate with one social support group, and they decided to opt out because we couldn't interview the entire 70 cancer patients. We could only interview about 20 cancer patients in their group, and they mentioned that this kind of interaction, that some are selected, others not, would bring tension to the community support, and so they rather abstain from the project, even though they really like the initiatives, for the sake of the good relationship among the cancer survivors. So let us always think not only from the individual, the family perspective, but also the social impact it might have, the studies that we conduct. Then, for sure, the level of stress. Several of the nicely designed cancer health literacy studies were just far too long, and we couldn't implement them. So we always need to balance it out, what is very sophisticated, nicely to do statistical analysis around, and what is more practical and more relatable for the cancer patients that we want to engage with. And then finally, also we encountered that people that we interviewed died during the process of the research. What do we do with this? And how do we honor them, even though they're not with us anymore? So what are some conclusions that we can draw from that very condensed way? It's patients are active contributors to their treatment, and we can strengthen their ability to take control, and it's a moral obligation. Narratives have the potential to improve cancer health literacy. All the cancer survivors demonstrate a very wide range of different experiences, and personal care and personalized support is needed. We have a cancer health literacy scale for Kenya that is validated now, and the website can help because it's acceptable and effective in improving cancer health literacy. We can consider that evidence-based medicine and evidence-based information can be combined with the lived experiences, and with this we have a holistic understanding of the life of people. Having said all that, I want to say a big thank you for all who supported that work. This is just a picture of how we conducted the interviews. Here are further information, and I'm looking forward to the conversations that we might have later on. Thank you.
Yes, thank you, Stephanie. So next we will have Peter Kailemia, because I'm not seeing Jackie Namulema here. So we'll go to Peter Kailemia and, oh. But let's just Peter go, and then you'll be the next one. Yes.
Thank you very much. My name is Peter. I'm from Meru University of Science and Technology, and I've got my colleague Victoria there from the University of Embu. Our fund is the Rising Tide Foundation of Cancer Research in Switzerland, and we are focusing on implementation science. Now, all of us here, from yesterday, we are talking about producing evidence, but there is a lot of literature that shows that it takes an average of 17 years for the evidence that is produced by researchers to find its way to policy and practice. So our subject basically is an implementation science project trying to bridge the gap between the evidence we have in early detection in breast cancer and the influences can have in the rural communities. I'm going to go through a bit about the background, the objectives, the framework that is involving the patient and public involvement, methodology, the impacts, and the framework that we are using to implement the trial, as well as the conclusions. Now, the fundamental point that we are trying to really
bring forth is to indicate that the persons who have had a disease, they have some important expertise in terms of the experience that disease itself, the individual experience, the context within which they experience that particular disease. It's very important that we, the researchers, the policymakers, actually may not understand. So if we produce evidence without considering the expertise, then we might get the evidence, but the evidence itself might not be able to optimally be taken up because we missed certain expertise of the persons who have lived with that particular disease. And that's really the fundamental point that I would like to put forward morning to you, the importance of the patient and public involvement so that we don't meet that useful aspect of individual and the contextual representations of the disease, and how then we can incorporate that aspect in our research, so that once we have the evidence, then the evidence has a high chance of being utilized from the time it's produced, the time it's finds its way to the policy and practice. There is a narrow gap than the historically established 17 years. That's really important to appreciate. And this is where we start about the background that healthcare research has made a lot of progress. The human life from 1950s really has improved because we have improved a lot of research and we have produced a lot of evidence. But this evidence is not finding its way to policy and practice fast enough. And the fundamental of implementation science is to ensure that that period is narrowed, that we spend a lot of money, the funders, the researchers, the governments spend a lot of money to produce evidence, but then it means that the taxpayers are not getting the value for the resources because government, the funders, they spend this money, but the taxpayers are not getting value fast enough because the evidence is there, but it's not finding its way. Now, involving patients and the public is an important aspect of trying to close that evidence practice policy gap. If we involve them, there's a likelihood they are going to uptake that particular evidence. Take, for example, since 2006, we entered the HPV vaccine. But if you look at the rate of uptake, like the government of Kenya, for example, it offers that as part of the free immunization. But if you look at the uptake, it's still far much suboptimal. And it's free. It doesn't cost anything for mothers and fathers to take their daughters. But still, there's a lot of barrier between the availability of the vaccine and its uptake by the general population. If we involve the patients and the public, then we can design better studies, and we have also a high likelihood that the evidence is actually going to be uptaken even by the consumers and, of course, the policymakers. So the study that we are carrying on, we are in the first phase of the study, which goes to ensure that we identify the patient and the partners and they are the stakeholders, and then we collaborate with them to develop a protocol, which then we forward for the funding for the second phase, which then we're implementing in Meru County. So what I'm presenting to you is basically the first phase, what we did in terms of getting the patient and the public, and how they helped us to develop a protocol, which then we were able to submit for the second phase funding, and we were able to get the funding, having already incorporated the views of the patient and the public. This is important because initially, for most funders, they demand that you get the patient and public involved, but they don't give you the resources. They don't give you the time. They do not give you the money to do the involvement. But the Rising Tide Foundation was able to do that. So the theoretical underpinnings for what we did, the Rising Tide Foundation has very clear guidelines due to the diversity of the subject matter of patient and public involvement, they have developed guidelines for the applicants, and we refer to these. We also refer to a model by Highton that tells us about to what extent do we involve. They are the patients, they are the family members, they are the caregivers, they are the rest of the stakeholders. To what extent do you involve them? And we have used the module, the model includes those terms like inform when you provide information. And if you look at from inform to defer, it's an increasing depth of involvement. And again, this depends on the characteristics of the patients and the participants. For example, if you got a breast cancer survivor who is also a researcher, like for example we have in our team, then they could be involved at the level of the collaboration or at the level of defer to, where you are given certain roles because they have the competencies. So that is an important model that we use to develop our model that we are going to show at the moment. We have the Patient-Centered Outcome Research Institute. Is an institute whose work is basically to promote the involvement of the patient and the public, and they have very, very strong, evidence about involvement, and we have referred to their principles, which emphasizes the diversity. There shouldn't be anybody left in the community as far as the subject you're studying is relevant to them. So the inclusivity is very, very important. And the inclusion should start pretty early in the research. And that's why we were forming we were developing the topic, developing the objectives. Then we involved the patients and also we involved the public. We also had a dedicated budget for the first phase. The funds that we were given basically were meant to ensure that we have an effective patient and public involvement. And that's why they called it a pre-application grant. So we got a pre-application grant to ensure that we actually have a meaningful engagement of the patient and the public. We aim to build capacity, and still as we go to the second phase, we are building capacity because we can have the patients, we can have the public, but they do not have the research competencies. They do not understand the subject of, for example, breast cancer. So it's our business to ensure we build capacity for them to effectively participate in our research. The inclusion of all the partners, like for example, the husbands and other persons. And of course, as we include them in the first and second phase of the project, which goes from 2025 to 2028, they shall be involved for these 3 years. And we need to continuously assess the impact of involvement, impact on the research, impact on themselves. Are they feeling satisfied with being involved? Do they feel they are making, some impact in the research? And ourselves as researchers, do we feel that they are being involved in a way that we are learning from them and we are formulating, the right kind of, we are generating the right kind of evidence? So the first phase, we did it in 2 counties, Nyeri County and also Meru County, and we used the community-based participatory research design, which ensured that all these categories of the patient and the stakeholders and their families, the patient advocates are actually involved. Now, who did we actually involve? Now, because of the importance the funder places on the patient partners. Now, the patient partners here means the person with lived experience, as well as their caregivers, the family members, the patient organizations, the patient advocates. So the phrase patient partners includes persons who have the lived experience and other persons that are very key to the small circle of that particular patient. And of course, then the other stakeholders. So these are the persons that we describe as the patient and public, so that all of them can be able to give us ideas about how best to implement the project. project. Now, during the protocol development phase, there was a lot of impact of this involvement. For example, we had to revise the research team. We had to include a breast cancer survivor who is also an epidemiologist, and we gave an active role in the second phase of the project, and the role will be to lead the patient and public involvement for the next 3 years. We also had to include as a co-applicant community-based organization, which is going also to co-lead the patient and public involvement in the next 3 years. Now, as we were trying to develop the topic and develop the objectives, the patients and the public really played a very big role. We used the WHO framework, which talks about the 3 pillars from the pre-diagnostic, the diagnostic, and the treatment phase. Our situation analysis focused on the pre-diagnostic and the diagnostic phase. But in our now second phase, we're only focusing on the pre-diagnostic phase because we collaborated with the stakeholders of the patient, and that became their priority to them. As much as we had some challenges in the diagnostic phase between imaging, between the labs, and there were a bit of challenges there, but in relation to the patient and the policymakers, their priority is ensuring women can come from their rural areas, go to the first level facilities, and then be able to get referred. So we are trying to create awareness to smoothen the referral system and then have navigators who are themselves breast cancer survivors to navigate these women, especially because of the different mates. Like, for example, if you get a mastectomy, you're going to die. So some women may recognize their breasts are changing and they need to go to the hospital, but because they fear mastectomy, which they think is going to cause death, so we require navigators who have that lived experience to navigate any lady who is going to be detected with any kind of symptoms. We as researchers also were able to learn a lot about some of the drivers of the advanced diagnosis, and these we are going to incorporate them in our formulation of the interventions. So this is the model that we developed from our first phase of the study. First, we developed for the situation analysis for the protocol development, and we are going to go ahead also to utilize this model along the implementation trial. And we are basing this on the works of ITON because we are identifying the phase of the project, we are identifying the depth of involvement, and we are identifying the activities for which we are going to involve the patient as well as the other stakeholders. As I finish, I need to give a word of caution. If you have to involve the patients and the public, particularly before you get the funding, you are not sure you are going to get the funding. And even when you get the funding, please do not overpromise. You have to effectively manage the expectations, particularly patients in the rural areas and the public. If they come for a meeting and you give them 500 shillings, they would expect perhaps they are going to continue getting that amount of money. And we have this kind of experience where after the first phase and we had a break to do the second phase application, I would receive calls from the patient, oh, it has taken a while before you called us for another meeting. Because they came and actually got a talk during that meeting. So they expect that, they'll keep being called frequently because they are rural folks, and it's a community that's of low socioeconomic status. So please, you need to manage expectations, particularly if you're going to do this before you get the funding. Because if you do before you get the funding and actually you don't get the funds, then if you're going to research the same population, they may have low really kind of belief in you in terms of what you can offer. As I conclude, now the Rising Tide pre-application grant really was very, very important to ensure we had a meaningful and impactful patient and public involvement in the protocol development. And now we have also a budget as we start implementing this project, we have a budget to ensure that we are continuously involving the patients and involving the public to ensure that by the time the project ends in 2028, we have evidence that is that owned by the patients, the policymakers, and everybody really who is going to be affected by that research. We have formed a community advisory board, which has got presentations from a spectrum of the patient, the public, and this will be formally incorporated at every stage, but also it shall be involving the rest of the persons in other settings. In the Equator website, which gives a lot of tools about reporting research, we have the GRIP tool or guidelines, which at the end of the project we are going to use to report how did we involve the patients and the public. Thank you very much.
So next I'll invite Jackie Namulema to tell us something about cancer caregivers.
That's okay. Yes, good morning, everyone. I'm called Jacqueline. So we had a very small study on the mental health of caregivers of people with cancer. We know that cancer does not affect only the patient, it goes on to affect all stakeholders in the fight against cancer, including their caregivers. And actually these caregivers are very important people in the fight against cancer, because they're always there for the patient. They give the patient care, and sometimes they are very important determinants of the treatment outcome. However, as they do the caregiving to the people with cancer, they are faced with a lot of challenges, including a change in their quality of life. Sometimes they lose their jobs. Sometimes they have to change their program so they can be able to fit in the patient they are taking care of. And the Kenya National Policy on Cancer Care, on palliative care, actually advises palliative care for cancer patients, and this includes a provision of services to all people that are involved in the cancer care, including the caregivers, the families of people with cancer. However, due to the limited resources that we have in the fight against cancer, the care is only given to the patient themselves, but not to their immediate family members and including their caregivers. So because of that, there is a strain on the caregivers themselves and including their mental health. So because of that, we went ahead to determine how caregiving affects the mental health of caregivers of people with cancer in Nyanza by using two centers. In Nyanza, we have 4 hospices, but because of the study was a small one and with no resources, we took up only 2 sites. That is Jaramogi Oginga Odinga Teaching and Referral Hospice, and then another hospice that is located in Mohoroni sub-county. We collected data using a modified hospital anxiety and depression scale. We modified it to be able to fit our study, and this scale has 2 sections. One section that determines the level of anxiety with 7 questions, and then the other that determines the level of depression. And then after we use a Likert scale to be able to measure the extent of the anxiety and depression. And on the tool, the last question was for the caregivers themselves to give a self-rating of their mental health status. And we This was a very small study, so but we got very good results. Actually, the prevalence of anxiety was 28.6%, and the major symptom was sudden panic attacks, especially related to the prognosis of the cancer patient. And then the prevalence of depression was 32.7%, and the major signs were carelessness and fatigue in their caregivers. So this is just a graph that showed the extent of the anxiety and depression in the caregivers. Most of the caregivers were actually normal, but we had those at the borderline and below the borderline, so that they are anxious or depressed were actually more than those who are normal, which indicates the extent of how caregiving is affecting their mental health, and then of course subsequently their quality of life. So for the self-rating of their own mental health status, most of the caregivers, around 47%, were not even sure of how they could rate their own mental health status. But some, of course, were not satisfied with their mental health status as they carried out the caregiving, and then the other were satisfied. The results of our study are, of course, in a general population, the levels of depression are lower, around 4.4% for anxiety and 5.7% for depression, meaning that in our study, the anxiety and depression in the caregivers in Nyanza was actually much higher than in the general population, meaning that the caregiving is actually putting a strain on the caregivers of people with cancer. And our results were consistent with other studies, but lower for other studies that were done in other areas because of different reasons, including the kind of methods we used in our study, since our study used the snowballing method, which is not generalizable. So which implications does this have for cancer care? So the poor mental health status of the caregivers is actually disadvantageous to cancer care, because caregivers are very important in total scale stakeholders in the fight against cancer. They give a lot of hope to the cancer patients, and if at all they are losing the hope themselves, then that would directly affect the cancer patients themselves, and subsequently could lead to poor treatment outcomes. Our study had a lot of limitations. Like I said earlier, it was just a very small study, just like a pilot study that was that we can always upgrade on a larger scale. It was non-probabilistic. We used snowballing. We didn't take into consideration the various types of cancer, but this is just a pilot study that can actually be expanded. And our conclusion was the levels of anxiety and depression in caregivers of people with cancer in Nyanza are high, more than the general population, and therefore regular screening and psychosocial support is required. Of course, this should be given to cancer patients, but as that is done, it should also be extrapolated to their caregivers, because they're very important stakeholders in the fight against cancer. So just a few acknowledgements. The study was done by researchers from Uzuma University in Kisumu, and then there are the two hospices that we got our sample size from. So thank you so much for listening.
Thank you so much, Jackie. So I'll ask all the speakers to just come forward, and if you have questions, just raise your hand, please. So all the speakers for the session to just come forward.
Yeah, I thank all speakers for the nice presentation. My name is Goodluck, a medical doctor from the oncology department in Tanzania, Uganda Medical Center, and I work mostly with pediatrics population. So I had two questions. One question is to Dr. Omar. As you said that radiation is an important part of cancer treatment, and we know that this important part of treatment has a lot of problems and complications to patients. It causes burden, side effects, mucositis, dermatitis, as you say, the transport to and from the hospital. So all that have a risk of causing treatment abandonment. So my question is on the patient navigation system. How does Garissa make sure that it's able to track treatment abandonment?
That's an excellent question. I would like just to acknowledge from the onset our patient navigation system is still in its infancy. We just started it. So it's a lot of challenges. You go there before you see there's organized chaos. People come here, someone gets their vitals done here, other one is going to clinic number 4. It was very, very disorganized. But now, since we started, it hasn't really taken off very well, but at least we're really trying to put together. So I don't have much success to report as of now. But I'm very proud that it has finally gotten off the ground. And you're right, radiation toxicity is very bad, and it is actually commensurate to compliance. But what we do is all patients who get radiation therapy do have a day in the consultant clinic for follow-up of assessment of toxicity. For example, any patient who has just started this week, the second week they have to see the specialist, and towards the end and during completion, they have to be assessed again for the long-term toxicity of radiotherapy and everything, and also given a follow-up date to come back. Yeah.
Yeah, thank you. My other question is to Dr. Jacqueline. As you said, you're looking at the anxiety and depression among caregivers. So I was curious whether there was any disparity between caregivers of like adult population vis-a-vis the pediatric population. But also another question, just a follow-up. I wanted to do a study to look at the burden of anxiety and depression among the caregivers where I'm from. So I'm curious on the tools that you used. Did you use the GAD9, PHQ, and what do you recommend on the tools that I can use?
All right, the study, like I mentioned, was a very small study. So it was just like a pilot study. So we are planning to do an extensive study after this. There are various tools that can be used. The one that you used, that is a modified hospital modified hospital anxiety and depression scale, we found was the best for this study. But we are having discussions to look at advancing the study itself, looking at the various of the cancers, the pediatric and adult populations. So that is all going to be done in the real study. Yes. Thank you so much.
Hello, everyone. I'm here. Great talks. I also have several questions, I think, for each of the speakers. So first is to Dr. Omar. Do you think that the machine downtime affects the numbers that are completing radiation? Because I noticed in Garissa, the downtime was about 300, was quite high. And in the other areas, Mombasa and Nakuru, it was lower and they had more patients. So I was just wondering if that kind of affects and puts off patients, so you lose patients.
Yeah, definitely. We had a mitigation strategy for that. So once the machine breaks down, we of course refer them immediately to Nairobi by giving them a proper referral and even making a phone call ahead of time. But I forgot to mention the data actually dates back to 2022 to 2025. So most of the breakdown actually happened the first year, where there are a lot of teething problems, service level agreement issues, fewer engineers on site. But actually, I'm happy to report from 2023, 2024, 25, where there were like very few. But there was almost a whole year once it was launched, the machine had issues, bit of administration and political issues between the national government and the county. But right now, that is secured in terms of the service level agreement. But definitely, it has really affected patients, even though we were referring them on time. Yeah.
Okay. Yeah, thank you for that. And then to Dr. Stephanie. So it's really interesting to see that the medical students and the nursing students are scared to even see cancer patients. And this is a question not to you, but also to the clinicians, the seasoned clinicians in the room. How does this then affect the future of oncology health professionals in the country? If we have students, is it part of training? Are they trained on taking care of oncology, patients, or is this after their medical degree when they're now doing their internship, etc.?
So we interviewed third-year students, both nursing and medical students in 3 universities. Here, Kenyatta University, Mount Ngina University, and Mount Kenya University. And we had the focus group discussions. And there, some answers could be relevant to answer your question. So on the one hand, they see cancer patients then in their placement. They are trained on oncology, but they reported, and also the lecturers confirmed, what they learn is primarily about the clinical side. The nursing students always brought up interacting with these stories help them to understand how holistic cancer support can look like. They always have the terminology holistic, but they're not prepared in that. Together with some lecturers from these universities, we've now developed 3 kind of modules, a short-term module that can be included in medical and nursing training, a half-day model, and a one-day model. And we want to roll it out in the next 2 months in order to see how can we use these stories as an add-on so that the stories can be used as second-hand learning. I would love to consider it like that, because you're not directly interacting already with a cancer patient, but slowly and steadily you can learn more about what it is for them, what bothers them. And we hope that this can be one option, but I'm pretty sure there are many other ways of how nursing students and medical students can be prepared. And I'm looking forward to learn it from you.
Yeah, thanks for that, Stephanie. It's good to see that, you're kind of thinking of incorporating this as well. And then, so to Dr. Kailemia and your colleague, now that we have the public and patient engagement, do you think this kind of trickles down to the wider community, because now there's kind of more awareness of what's going on? Those that are involved, are they passing on the messages to, the rest of their families or friends to kind of demystify some of the myths that may, be going around? Or are they just keeping it to themselves? I'm just asking out of curiosity.
I think I'd like to say that most of our societies, their decision making is collective rather than individual, which is a big feature for the West. So the cultural sensitivity of involving the patient and the public ensures that the study is culturally sensitive, and therefore the persons involved, they can be able to share this information with their family members, and there's a deeper buy-in and a sense of ownership, so that if the county government of Mary, for example, and other counties would want to scale up this project or incorporate it as part of, the normal care that they're going to give, then the culture has been considered. Therefore, the likelihood of the the public able to go for screening, or for example, to have the clinical breast exam is likely to take place, because then it's culturally sensitive. The services will be delivered in a way that they're culturally sensitive, that is responsive to the needs of this particular population. Yeah, and of course, then the policymakers and the administrators also are likely to find the sense of this project in terms of addressing advanced diagnosis, which is again a big problem, and actually that is going to cause much that causes much of the deaths is because of the advanced diagnosis, where most women are being diagnosed stage 3 and 4 instead of stage 1 and 2. It is because women take a lot of time to present with breast changes, even when they take place. We have cases where a woman would stay for like 1 year, 6 months. And according to WHO guidelines, if you stay with the changes for 3 months, if they actually breast cancer, that tumor characteristic is going to change and it's going to upstage, and therefore the prognosis is going to be extremely poor. So it's not enough to make services available. It's another thing for the target population to utilize the services. So if you make them culturally sensitive, then it's likely that they are going to be utilized by the target population.
Thank you all for your answers.
Next question. Francis.
Thank you very much. Mine is I don't know whether it's a question or a comment. My name is Francis Makoha from Mount Kenya University. Just building on what Dr. Kailemia has said, last year I was in Meru with a group that was engaging the community, government and community. And one message that came from certain areas like Igembe and the rest, where they report very high cancer cases, was the cancer is so stigmatized that when somebody is diagnosed with cancer, the next thing is they know this is a dying person. Now, I don't know in your interaction if that has come up, and how do you think, what is the suggestion to best address that? Because that could also be contributing to the late diagnosis. I realize I have a problem, I have a lump in my breast, but because of the fear that I may be exorcised from the community, I don't just go for medical checkup, even if I know what I should do. Yeah, so I don't know how your study if it's coming across such, and how you intend to address it.
Thank you very much, Francis, for that. Yes, it's really a big problem. Cancer stigma is a very big problem in the community, and we are incorporating patient navigators. We are doing the study in 2 sub-counties because it's an implementation randomized control trial. So we are using 2 sub-counties. And for the intervention group, we have patient navigators who have lived experiences, the patient experts, so that in case the lady develops any changes in the breast, then they can be navigated from their communities to the level 2 and 3 facilities, and then to the referral hospital, where all the symptoms are going to be evaluated. That way, if we pair them with somebody that lived experience who have been treated, then it's likely they are going to kind of debunk the myths that surround breast cancer and other forms of cancers.
Next question.
Yeah, maybe I can just add 2 other things that we're doing for the study. Apart from the patient navigators, who we are calling peer navigators, we also have, you'll realize Meru is which is similar in a lot of communities, is very patriarchal. So you have the issue where we include the husbands or the partners in trying to ensure that the women are going for their checkups. That's one of the ways we are looking at it. And then also using what is known as the leaders within the community just to pass the message around. Those are some of the ways we are trying to deal with stigma issues and to ensure that women are actually going to the facility.
All right. So, Jacqueline, I would like to follow up on probably if there was any observation on the mental health of the caregiver, if there was any relationship between the mental state of the caregiver and the treatment response of corresponding the cancer patient. Was there any observation in the treatment response, maybe?
Not really. Maybe the question that was related to that is if at all the prognosis of the patient caused any anxiety in the patient, but the question about that particular one was not included in the questionnaire. Yes.
Okay, there's one more question here.
Thank you so much. My name is Mary Ndong. I wish to ask a question to Dr. Stephanie. Have you been able to carry out an impact evaluation? Having that you're using Maishana Cancer website, how many people have accessed the website? Is there any impact that we can easily relate with? Thank you.
We haven't checked the numbers of how many have actually accessed the final end, but we had half a year ago when we checked, it was more than 3,000 who actually interacted with it. And also the tiny problem that came up and our nursing students kind of like referred us to is that a lot of the nursing students downloaded the YouTube videos and watched them at home, so they're also not showing up on YouTube that we can see, okay, these are the numbers. So it's more the technical questions where we saw that not everyone who interacted with it actually can be traced because it needs a certain number of seconds that you also watched it, etc. The impact was what I presented at the end, where we had a pre-post study. We opted not to do a randomized control study because we wanted to have first-hand data in order to see whether it actually can work. But we have some plans to carry it out also in other contexts when we get some grants to do that in order to have a randomized control study as such. But we also know not everyone engages with online videos the same way. We know that with this approach, we can't reach everyone, but we can definitely reach more than only those who are in the city who can attend the cancer support group meetings one time a month. And that's what we wanted to reach. But very important questions. Thank you.
My question goes to Jacqueline. Why did you choose to use the snowballing as a sampling method?
Yes, we are. At first, we used systematic sampling, but realized that it was very hard to get the number of caregivers that we wanted because very few of them were available. Since when they come to the hospice, because the hospice is small, they are only there for a short while and then they go back to their homes. So systematic sampling could not work. We could get like maybe around like Mohoroni Hospice, we could get like 5 patients in a week. And so when we look at the caregivers, it was going to take a very long time if we use the systematic sampling. So when systematic sampling failed, we now went to snowballing. So those we got could now refer us to other caregivers because they had a support group, and then we would get a higher sample size. Although it comes with a lot of challenges, and of course the results cannot be generalized. But remember, this was a pilot study. It is not. We are going to do another study. I think during that time, then we can be able to use better methods.
Okay. Thank you very much to our speakers from the advocacy session. Can we give them a round of applause? Yeah, so now we'll go for tea break, and then when we come back, we'll have our second keynote address. And then for those who are not here in the morning, there's likely to be a very big storm in the afternoon. and we were planning to do exhibitions late in the afternoon, but we can't do that if it's raining. So we will have to shift around some talks, and we just ask our speakers in those sessions to bear with us, but I'll find you personally and inform you. So now we can go for tea break, and then we come back at 11 for our keynote address. Thank you.
Music. Paparazzi, Don Julio, Don Diami, Ekumedula, Keep stars out, as a metro, yeah, Ekumedula, Keep stars out, as a metro, Funny we are seeing here because of you have to go to me here. If you see me, shoot over by, if you shoot us up there, let's speak. You go, it's me, tell you, I can't talk to me like this. We have vow, we are wow. We are no. So, Minister of Enjoyment, it's a continental. One meter, go live forever. We are not the backer. The bad must be better. Sasa, we can't forget your man.
You broke my consistency every day, and you never thought that I would be okay. You lie to me. You make me want to freeze. Come back on your knees. Oh no, oh no. See, you no go get again, or you won't get again. Make you no disturb me, cause I know what they mind you. Oh no, it's too late. It's too late. It's too late. It's too late. You lost a good one. My love is yeah. Oh, yes, it's too late. It's too late. You lost a good one. My love is yeah. Oh, yes, pressure rising. I can't think it when you see sexy body. See, yeah, when it's time, this one, first time, this time, you put
It's the kiss, baby. Koma kunichokonoa, kunifata kuna muda vinaboa. Akutanitia doa, nile naye moyo wake tishuta loa. Najua nakuudhi, wewe sasa mmekusipima ujuzi. So select attitude, kubishana, I'm not in the mood. Niko salama, sijui wewe uko. Unapewa nyama kwa nyama, sijui wewe uko. Niko salama, sijui wewe uko. Kuinamana, sijui wewe uko. Usiniulize hali, niko very good. Nimekosa nimenona. Mwenzako mimi niko very good. Nimekosa nimenona. Alhamdulillah, angenioa yule. Maana mtu si mtu, jini si msukule. Hivi mapenzi gani, apigana kama shule. Mina mwabubu, iya nanitoa. Ningelitoa. My God. Darling, wangu mimi darling, Charlie, wako mimi Charlie. Oh, you for me water, make a shot my shoulder. Tell your mama that she got that pretty daughter. Motoring you can keep it Melody, sweet melody.
Do anything that you wish. Me share my love, so don't tell me for them. No easy to hold. Somebody else gonna take your head. Don't do me no more. It's still not being no more. You know what to do more. It's don't give me trouble. You don't do me no more. It's still not being no more. It don't be my pick you up in the party, bring it on what is on your mind. You're being it is a bunny and candy. I know that you promised to show and tell me no time for so when I'm right here. You and I together, so we go together, so we both know piano, both see a fly, we say Life with you, girl, me love it. Life with you, tell them forever. Life, we say diamond rings in your body, darling, come find me. Oh, you did do me no more. This thing don't do no more. Don't want to do more. This don't give me trouble. This thing don't be no more. Never too far from my baby. I just want to call your number. After my person, who will take my pain away. I get better for now. I don't want to be so jealous. You can leave me, baby. It's just so fine. I gotta want you forever. Something nice, I don't mind. Yeah, I mean, I mean. Because so don't tell me for you. I don't want you to go. Somebody else don't keep on you. Don't do me no more. This thing don't be no more. Don't want to do more. This don't give me trouble. Don't do me no more. This thing don't be no more. Don't do
Person you ain't no person, you know they keep person. If you want no person, you know go first person. I'm not the sick, you won't give me medicine. I got money, you won't help me spend my money. Allow me to enjoy myself. Allow me to enjoy myself. Allow me to enjoy myself. Allow me to enjoy. Allow me to enjoy myself. Allow me to enjoy myself. Allow me to enjoy myself. I love you. I'm a winner. I'm a winner. Just believe that I'm a winner. Just believe. I'll never do it like you do it. Just believe I'm a do it. Do it. Yeah. Let me do it like I do it. How I do it. Allow me to enjoy myself. 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 Allow me to enjoy myself.
It's the kids, baby. Yule mtoto wa jana kanifanya kama sijielewi. Yule mtoto wa jana kanifanya kama sijielewi. Yule mtoto wa jana kanifanya kama sijielewi. Yule mtoto wa jana kanifanya kama sijielewi.
Panauma, Panawasha, Panauma, where you got Panauma, Panawasha, Panauma. You don't talk to a young man from Mama Sidney. Now you talk, pota. Look, check it home, I'm a UTI, Nipime down, I'm a malaria. Look, check it home, I'm a UTI, Nipime down, I'm a malaria. Look, check it home, I'm a UTI, Nipime down. I'm a malaria. Look, check it home. I'm a UTI, Nipime down. I'm a malaria. Pull up in a cream, too much too clean and tall. I'm Foster, serious and dirty. A big time player, trip too big and kind. I went Foster, Tina said gym, too hard like a heater. My neck and froze, I went, I'm very young. Liquor, shy song, picture, MJ in the sheet, thriller, fully vibes every night. Yes, non-tolerant, poster, a style like folk. Pull up in a beam, too much too clean and tall. I Foster, serious and dirty. A big time player, a trip too big and kind. I went Foster, Tina said gym, too hot like a heater. My neck down froze, I went, I'm very young. Liquor, shy song, picture, MJ in the sheet, thriller, fully vibes every night. I forget. To the girl, the best. To the full center, on time I got you, the living of a dance. Oh yes, my baby's a oh yes. My baby's a oh yes. If all this, if you go down, period, I'm not the very. I forget. To the girl, the best. To the full center, on time I got you, the living of a dance. Oh yes, my baby's a oh yes. My baby's a oh yes. If all this, if you go down, period, I'm not the very. Pull up in a beam, too much too clean and tall. I Foster, serious and dirty. A big time player, trip too big and kind. I went Foster, Tina said gym, too hot like a heater. My neck down froze, I went, I'm very young. Liquor, shy song, picture, MJ in the sheet, thriller, fully vibes every night. Yes, non-tolerant, poster, a style like folk. Pull up in a beam, too much too clean and tall. I Foster, Serious and not, yeah, a big time player. A clip too big and kind. I went, face, yeah, Tina said gym, yeah, too hot like a heater. My neck now froze, I went, I'm very young. Clicker, yeah, show some picture. MJ in the sheet, thriller, fully vibes every night. Pull up in a beam, too much too clean and tall. I'm faster, serious and not. A big time player, trip too big and kind. I went faster, Tina said gym, too hard like a heater. My neck now froze, I went, I'm very young. Clicker, show some picture. MJ in the sheet, thriller, fully vibes every night. Poster, I can style like folk. Pull up in a beam, too much too clean and tall. Foster, serious and not. A big time player, a clip too big and kind. I went, Foster, Tina said gym, too hot like a heater. My neck now froze, I went, I'm very young. Liquor, show some picture. MJ in the sheet, thriller, fully vibes every night. Don't forget, the people are the best, beautiful center, automatic jet, the living of the best. Oh yes, my brothers are oh yes, my brothers are oh yes. 40, if you go down, period, I need to make a
Style like folk, yeah. Pull up in a beam, too much to clean your toilet. I don't force it, serious and other. A big time player, trip too big and Ghana. I went flexing, yeah. Tina said gym, yeah. Too hot like a heater. My neck done froze like winter. I'm very young, liquor, yeah. Shots told me picture. MJ on the sheet, thriller. Fully vibes every night. Answer, Nankala, Costa, yeah. I can style like Fogger, huh? Pull up in a beam, too much to clean your toilet. I don't foster, serious and other, yeah. A big time player, a clip too big and Ghana. I went flexer, yeah. Tina said gym, yeah. Too hot like a heater. My neck done froze like winter. I'm very young, liquor, yeah. Shots told me picture. MJ on the sheet, thriller. Fully vibes every night.
Saa saba yangu siku ndo unaniita nije kwako, ila siku nzima siku sijaona simu yako. Eti nije tuongee, unafaa masiara, unaniona mikenge, unaniona mimifara. Siendi wanako siendi, azuma ya kutolea lakini siendi, nauli yake nakula lakini siendi. Siendi, nasema si, ay mama siti,
That's fine. Yeah, I think this way.
Ololufemi, you know you always on my mind. I think about you every time. Wako siemi, Ololufemi, you know you always on my mind. I think about you every time. Wako siemi, Wendo usingizi, wendo wamuli waza, nazibana masikio, hakuna kunipumbaza. Natamani masaa yangerudi nyuma. Mimi na wewe, tungejuana zamani. Oh Lolo, Ololufemi, oh Lolo, you know you always on my mind. I think about you every time. It's the kids, baby. Wako siemi, oh Lolo, ni leo. Acha tu niwaweke wazi.
Hello, can you please settle down? And those who are outside, please come in so that we can start the second session. So welcome again, everyone, to this session. So the next speaker is going to be John Hartley, who is a professor of cancer biology and currently affiliated with the University College London Cancer Institute in the United Kingdom. And he's going to be talking to us about antibody drug conjugates. Anybody here has heard of antibody drug conjugates? Raise your hand. Just raise it up high if you've heard of antibody drug conjugates. Yes, so those who don't know, maybe this is a time to learn. All right, welcome, John.
Good morning. Thank you very much for that introduction. And indeed, thank you, Victor, and everyone for inviting me to speak at your conference. Can you hear me okay? Okay, great. So, antibody-drug conjugates. So hopefully by the end of this, you'll know a little bit more about them. It's what I've been working on for many years now. And when we take a look at cancer therapy, particularly drug therapy, we of course give cytotoxic chemotherapy. We're used to doing that. And we know that it lacks specificity often, that there are many side effects. There's significant systemic toxicity, and we know it has a narrow therapeutic index. Nevertheless, we do the best we can with these types of drugs. We also give therapeutic antibodies. A good example of this would be Herceptin for HER2. We heard about HER2 yesterday in breast cancer. And these antibodies, they're very different to cytotoxic chemotherapy. They have specificity for a particular target, in Herceptin's case, for HER2. And they have a much better safety profile. And because of that, their therapeutic index is much wider. But they're often limited in their anti-tumor activity as single agents. So what do we do as medical oncologists? We combine often cytotoxic drugs with antibodies when we're treating patients. So what are antibody-drug conjugates? Well, this is a different way of combining the two. The principle here is that we combine the anti-tumor potency of a highly cytotoxic drug with that selectivity and the favorable pharmacokinetic properties of antibodies, and we combine them in a single molecule. So if we were to design an antibody-drug conjugate, what are the things that we need to consider? And we know over many, many years now that it's more complex than it seems, and all of the different components of an antibody-drug conjugate need to be optimized. The first thing is the right choice of target, the antigen target. This is something that is expressed on the surface of the cancer cell, so it could be HER2 in breast cancer. It needs to have relatively high expression on the cancer cells, and it needs to be fairly tumor-specific. Tumor-specific would be great, but most tumor antigens do have some expression elsewhere, but you want high expression in the tumor compared to normal tissue. And if there is normal tissue expression, then you hope that it's not in critical tissues. Then it's the antibody itself. Of course, this needs to have high affinity and avidity for that target on the cancer cell. And the other important property is that once it binds, it then internalizes. And that's very important because you want the antibody to then take the drug that you're delivering inside the cancer cell. And then there's the drug itself. We sometimes call it the warhead or the payload of the ADC. And that should be something that has very high potency. If you can deliver it inside the cell, then you want it to act with high potency. It needs to be a drug that you can link to the antibody, obviously, and it needs to have suitable properties so it doesn't change the antibody too much once it's bound. And the final component for consideration is the linker, how you link the drug to the antibody. This obviously needs to be stable in circulation because you don't want the drug to fall off in circulation before it gets to the cancer. But then you need some mechanism whereby the drug is released once the antibody has taken it inside the cell. And of course, it needs to be stable upon storage. And if you get all of these things right, the hope is that you'll be able to widen that therapeutic index, which we know is very small for free cytotoxic drugs. But if you can effectively lower the minimum effective dose by delivering the drug only to the tumor, and increase the maximum tolerated dose of the ADC overall, then that widens the therapeutic index and makes it a much safer therapy. And we know from preclinical studies that this is achievable with a lot of ADCs and a lot of different targets. Now, of course, the idea has been around for a long time. People tried to combine antibodies and drugs way back into the 1970s, initially non-covalently, and then covalently linking them. And indeed, the first human ADC clinical trial was in the 1980s, but they were not successful. And they were not successful for a number of reasons, because the technology wasn't advanced enough. And the other thing was that people were trying to deliver the cytotoxic drugs that we normally give to patients, drugs like cisplatin, vincristine, and so on. And that was found not to be effective enough. But then things changed in the 1990s, and scientists were able to get curative efficacy of ADCs in animal models, and the first ADC was approved in the year 2000. This was developed by the drug company Pfizer. It was targeting an antigen target on acute myeloid leukemia. And it appeared to be very effective, although subsequently, unfortunately, 10 years later, Pfizer withdrew the drug temporarily because of toxic side effects in some patients, although they've now re-licensed the drug with a different schedule. And following closely on from Mylotarg were two other ADCs, Adcetris, which targets an antigen on non-Hodgkin's lymphoma, and Kadcyla, an interesting example, the first ADC to target solid tumors, and this used that antibody Herceptin, and attached to a drug which has better efficacy than Herceptin alone. So this was really the first phase of ADCs, the first generation. So what were the drugs that were used in those ADCs? Well, I've already alluded to the very first ADCs that didn't really work very well because they tried to target the drugs that we use in the clinic. And if you look here, this is the potency of those drugs in molar. So 10 to the minus 6, that's micromolar, and going down. And the drugs that we use are active in around the micromolar range. But the problem was that you needed to put so many drugs onto the antibody, 10, 15, 20 drugs to be effective, that it was changing the properties of the antibody and indeed the stability of the antibody and so on. So what this first generation of antibody drug conjugates did was look for more potent warheads. And they moved away from the drugs that were used in the clinic, and they looked to natural products. And these three classes of natural products emerge. And now you can see that their potency has moved to the left. It's now in the nanomolar range. And these are natural products. And in fact, calicheamycin comes from bacterial sources. Auristatin drugs come from the sea hare, that strange-looking creature in the middle there. And the one that's perhaps interesting to this audience is that the other class of drug, the maytansines, the one that's on the HER2-targeted drug, actually comes from a spiny bush that's found here in Kenya, Maytanis ovatus. And we know the mechanism of these drugs. The calicheamycin is a DNA cleaving agent. It cuts the DNA in the same way that radiation does. And the other two are antimicrotubule agents that stop cells from dividing. And these were the drugs that were used in those first generation ADCs. So a little bit more about them. How were they attached to the antibodies? How was the conjugation done? Well, in the case of Mylotarg and Kadcyla, this was what we call stochastic, and it was attached to lysines. So an antibody, an IgG1 antibody, has about 40 lysines in its structure, the amino acid lysine. And you can use that because it has an amino group. You can use that to attach linkers to. And that's what was done here. And in fact, if you control the reaction, you can control the number of drugs that are attached to the antibody. And in this case, with these drugs, it was around 4, although what you end up with is a mixture from some antibodies that have no drugs to some that have up to 8, with an average of around 4. Adcetris was slightly different. The drug there was attached to cysteines via a linker. In an IgG1 molecule, there are 4 disulfide bridges, which you can release, which you can, excuse me, you can reduce and open up, and that allows you to attach the drug at these positions. And again, if you control the reaction, you can make an average distribution, what we call the drug-antibody ratio, of around 4. And that was what was found to be best for attaching these drugs. But you have to be careful when you do this, because the type of conjugation, and indeed, the more drugs you put on, the more likely your ADC is to have unfavorable properties, such as aggregation, or that it doesn't bind as effectively to its antigen binding site. And in fact, it can change the pharmacokinetics and be excreted much more rapidly. The other thing about these is that they differed somewhat in the linker. So as I said, you need a cleavable linker that's cleaved inside the cell. And that indeed was what was the case with Mylotarg and Adcetris on the left here. They had cleavable linkers, but using different principles. They were cleaved in the lysosome, a component of the cell which breaks things down, and it's very acidic. And Mylotarg used that property to release the drug. The linker was acid sensitive and broke down to release the drug. In the case of Adcetris, it used an enzyme in the lysosome to cut a dipeptide linker. Kadcyla was interesting in that it had a non-cleavable linker, which made it very, very stable in circulation. And it's only cleaved in the lysosome when the lysosome completely cleaves the antibody into its component parts, into all the amino acids. And so you end up with a drug with an amino acid attached to it. And the difference, the consequence of that is that those that have cleavable release the drug, and that drug is now free to go and kill that cell, but it can also move out of that cell and possibly kill an adjacent cell. So what's what we call a bystander effect. And that's quite important for a lot of ADCs, particularly in solid tumors that can be quite heterogeneous in their expression of antigens. In the case of Kadcyla, you don't get any bystander effect, because when it's released, it can't get out of the cell. So that was the first generation and the properties of those ADCs. And by 2017, everybody was focusing on 2 classes of anti-mitotic agent, the auristatins and the maytansines, those that are used in Kadcyla and Adcetris. But the problem here is, and this is where we came into the scene, the problem is that not all tumors are sensitive to these drugs. So there's some cancers that you can treat very effectively, but others that really aren't that effective. So what the field were looking for were different types of drugs to attach to antibody drug conjugates. So the requirements were that they should be very potent, they should be very cytotoxic to cells, they should be relatively hydrophilic, have relative hydrophilicity, so that their properties were good when they attached to the antibody and you didn't cause aggregation. They needed to have lack of resistance and a suitable chemical handle so you could attach them to the antibody. So people, drug companies and academics were looking around for these types of agent. And 2 novel classes came out of this. One were camptothecin analogs. These are inhibitors of topoisomerase 1, which are a class of anti-cancer drugs. And another one were these pyrrolobenzodiazepine dimers, or PBD dimers, and these are the ones that we developed in my laboratory. And these are DNA interstrand cross-linking agents. And we knew that if you damage DNA in this way, and you cross-link the strands together, it's very, very cytotoxic for a cell. If it's not repaired, the cell will die. And in fact, that's the principle of a lot of the chemotherapy that we give. The platinum drugs, cisplatin and so on, and the nitrogen musters, melphalan, cyclophosphamide, these are all cross-linking drugs. And we'd spent a long time trying to develop novel cross-linking drugs from first principles. And we looked to nature as well. And we were interested in a class of drugs which are called the anthromycins. These are made by bacteria, and they're very interesting molecules because they get into cells, they go to the DNA, and then they bind to DNA. And the bacteria have evolved them for some reason to do this. And once they bind to DNA, they then attach themselves to the DNA. And you can see, hopefully you can see, on the DNA structure on the left there, maybe you can see some green, and that is the drug sitting in the DNA and attached to the DNA. And nature has evolved those drugs. And what we did was we said, could we put two of these drugs together synthetically and make something that would also bind to DNA, but now would bind twice, and in that way cross-link the DNA. And so we developed these agents here. These are naturally curved agents that bind to DNA in one of its grooves, and then they attach themselves to both strands of DNA. And this is very, very cytotoxic to a cell, because when the cell tries to divide, it can't, because the DNA strands are linked together. And some of the agents that we made were 1,000-fold better at producing cross-links than some of the drugs that we use in the clinic against cancer patients. And here you can see one of these. Now you can see the green much more easily. And this is one of these synthetic drugs binding to the DNA. And the first of these drugs, the one at the top, we actually took to patients as a novel chemotherapy agent, and it showed activity against leukemias and against platinum resistant ovarian cancer, amongst others. But we were able to continue with the development of these types of drugs and make them even more potent. You can see the one at the top is potent in the nanomolar range. So that makes it similar to those natural products that were used in the first generation of ADCs. But you can also see that it's possible to increase the potency even more through to the picomolar range, or even the sub-picomolar range, this agent at the bottom here. Now, these are just too active to be given systemically, but they would make great warheads for antibody-drug conjugates. So that's exactly what we did. And if you look at the potency, you can see that the first generation warheads moved to the left, and now we have agents that are even further to the left at the picomolar activity. So we set out to develop these agents as ADCs, attaching them to antibodies. The first one we did in collaboration with Seattle Genetics, the company that had developed Adcetris, because they wanted new warheads. And we developed a linker strategy. The problem was that this is, if you look at the top molecule, and if you know any chemistry, this is a very hydrophobic molecule. It's very difficult to work with and attach to antibodies. But nevertheless, we persevered, and several of these went into the clinic. One of them was to challenge calicheamycin, Mylotarg, and if those of you who are familiar to looking at these waterfall plots, this is from the phase 1 study. Each bar here is a patient, and the bars coming down are the patients that responded to the drug. And you can see here, a lot of them, the bars went all the way down, which meant that these patients had a complete response. And these were patients with acute myeloid leukemia who had not responded to other therapies. So it looked very, very promising. But for various reasons, these agents weren't developed, partly because they were very difficult to work with. But in the meantime, we'd taken an easier scaffold, the drug at the top, which was still potent, not quite as potent as the one on the left. And we developed another way of linking it to a different position on the drug. And this was a drug linker that we called tesserine. And we actually formed a company to develop these agents called ADC Therapeutics. And so what we now have is our antibody drug conjugates that link to cysteines on the antibody, and they have a linker here. There's a spacer. That D peg is to make the properties better, make them more soluble. And then we have a dipeptide, this val-ala, which is valine alanine, and that's where it's cleaved inside the cell. And then we have a PABA group, which is in chemical terms, it's a self-immolating group. Well, what happens is that when the cell cleaves that linker at the val-ala, then the linker collapses and the drug is released. And so that was a clever mechanism. And what we were able to find was when you attach these very potent drugs, you only need to attach 2 to an antibody. That's enough to be very, very potent. And they behave very well. You get a single peak, they're very stable, they don't aggregate. And the properties of the ADC are not changed from the antibody alone when binding to its target. So we designed them to bind to cells and to do this mechanism, to bind, to internalize, to go to the lysosome, be cleaved, and then the drug would go to the nucleus, cross-link the DNA, and then kill the cell. And indeed, this is what we were able to show. These are cells. Hopefully you can see the blue is the nucleus of the cell, staining the DNA. And you can see on the left the antibody drug conjugate binding to the cell surface. The cell on the right there doesn't have the antigen target, so there's no binding. But when the cell expresses the antigen, maybe it's HER2, then you can see binding immediately. And then within 1 hour, hopefully you can see that now the antibody has gone inside the cell. It's been internalized. And then, don't know, quite difficult to see, but there is also red. There are red dots in the cytoplasm. Maybe you can see in the top right. These are the lysosomes. And then we know within 2 hours, the ADC localizes with the lysosome, and that's why it becomes yellow. And at that point, the drug is released. And we know it's released because we can measure the cross-links in the cell. So the drug is released, it goes to the nucleus, and it damages the DNA. And we can measure that, and you can see that on the top left there, where you see the ADC, there's a time lag, and then the cross-links increase. And that time lag is the time that it takes for the ADC to get to the lysosome and release the drug. And then we can follow the events that happen. The cells can't divide, they go into arrest, and then ultimately the cell dies. So that's what happens at the cellular level. What about in vivo? Well, this is a typical in vivo experiment. So this is a highly a very fast-growing tumor. It's a lymphoma in an animal model system, and you can see how fast it's growing. And if you give an ADC that is an antibody that doesn't bind to the cancer, it doesn't have any effect at all. But if you have an ADC where the antibody binds to an antigen on the surface of that cancer, you can see that a single dose, you can stop the growth of the tumor, and indeed, you can completely eradicate the tumor in the animal model system. And this is at a very low concentration, 0.5 milligrams per kilogram, so quite a low concentration of antibody. So in vivo, very, very effective. And we know that the maximum tolerated dose in these animals is above 9. We didn't go above 9 because it was taking up too much antibody. So we have a very large therapeutic index. And the ADC behaves very well. The pharmacokinetics are very good. It has an excellent half-life, and it's completely stable in circulation. So we went into the clinic initially against 2 targets, both in hematological malignancies, where proof of concept is often easier for ADCs in hematological cancers. The first was targeting an antigen on the surface of certain lymphomas, and that's CD25, and that's the one on the left. And that's an antigen that's expressed in Hodgkin lymphoma. And on the right was a target in B-cell lymphomas and leukemias, and this is CD19. And that's expressed on the majority of acute lymphocytic leukemias, B-cell lymphomas, and B-cell leukemias. So the first to go into the clinic was the one targeting the Hodgkin's lymphoma, the CD25. And you can see here results from the phase 1 study. We had to go in very, very low doses because it was the first in man for this type of ADC. And there were 133 patients in this clinical trial, and more than half of those were Hodgkin lymphoma, and the others were non-Hodgkin's lymphoma. And you can see that the overall response rate, even taking into account starting at a very, very low dose, was over 50%, nearly 60%, with 30% having a complete response to the ADC. And the maximum tolerated dose was not reached. And in fact, if you focus just on the Hodgkin's lymphoma, you can see that the response rate is 71%, with 42% complete responders. And at the optimal dose, which was found to be 45 micrograms per kilogram, that response rate was 86%, with half the patients having complete responses. The other agent, the one targeting CD19, also went into the clinic at a similar time, and I could show you the waterfall plots and the percentage response rates, but I think a picture is worth 1,000 words, as they say. And this is one of the first patients that was treated. This is a gentleman, 69-year-old gentleman, who had extensive B-cell non-Hodgkin lymphoma. And he'd failed all treatments to date. He'd had all the standard treatments, and he had just progressed through them. And here on the left, you can see a PET image, FDG PET image, and what's highlighted are the areas of the lymphoma that light up. And after a single cycle of this ADC, you can see that this patient had a complete response. All of his lymphoma had gone. So this latter agent progressed more quickly through the clinic. The first patient was dosed in 2016 in the phase 1. The FDA in the US granted it orphan drug designation, and then it went into a pivotal phase 2 in 2018. And then it was granted accelerated approval in 2021. In Europe, it was also granted orphan drug designation and is now approved in Europe, and it's being rolled out worldwide. So that is the story of our ADCs, and we're continuing to develop them, some of these against solid tumors. And the field itself is growing, and there are lots of attempts to find the best-in-class ADCs. We talked about Herceptin, which targets HER2. That's been around for a long time, and I know it's used here in Kenya. And I mentioned Kadcyla, which was one of the first-generation ADCs. That has a better activity than Herceptin. It's an antibody-drug conjugate, but it's a non-cleavable linker. And the next generation of ADCs have Herceptin, that same antibody, now with a different warhead, a topoisomerase 1 inhibitor. This is 8 drugs per antibody. It's a less potent warhead than ours, but for a solid tumor, that's sometimes an advantage. And this was approved in 2019 against HER2-expressing cancers. And whereas the other agents, your HER2 expression had to be high or amplified, with now it can target low-expressing HER2. And in fact, in 2024, this agent on the right was approved as an agnostic. So it's an indication-agnostic ADC. So any tumor that expresses HER2, you can treat with this agent now. So the field has exploded from those early beginnings. And it is, in fact, I said here it's one of global biopharma's biggest growth areas, but I think it is the biggest growth area in oncology therapy. You can see here the number of approvals up to 2023, and in fact, just to update it, there are now 17 approvals worldwide of antibody-drug conjugates, 13 in the United States. And there's more than 300 in clinical development. So we have been able to widen the therapeutic index, at least in those that the ADCs that have been approved. But there have been many challenges along the way. Preclinically, most of these ADCs work extremely well, and you can cure tumors in animal models. But when you get to patients, there are often unforeseen barriers. So in the clinic, some work extremely well, some work okay, and some don't work very well at all. And we're still understanding how to optimize this. And we have to realize that more than 100 ADC programs have been discontinued. They either haven't made it into the clinic or have failed in the clinic. So there's still a lot to learn. And the challenge is finding that right combination of the antibody, the right target, the right conjugation strategy, the right drug linker, the right number of drugs to put on the antibody, and indeed the right clinical indication for a particular ADC. And we need more predictive preclinical models. We have to change the way that we do clinical trials. They need to be more innovative. And we need rational clinical combinations. And we've just got results from our drug, Zynlonta, at the top there, in a combination study. And if you put things together rationally, you can have spectacular effects. So relapsed and refractory diffuse large B-cell lymphoma. This is the target of Zynlonta, the drug that we developed that's been approved. And its overall response rate is around 50% in these patients, and the complete response rate about 25%. There's a bispecific antibody, a BiTE, that's also been approved, and that has a response rate of 46% and a complete response rate of 27%. So not dissimilar in this very hard to treat relapsed and refractory setting. But if you rationally combine them, and results have just come out from this study, your overall response rate can go up to 96%. And the complete response rate, so no evidence of cancer, 91%. So I think I've probably used up all my time, but where is the field going? So there's a huge amount of excitement in antibody-drug conjugates, as you can imagine. And many academics and drug companies and biotech are looking to optimize this field. People are looking at different formats for the antibody, using bispecific antibodies, using smaller fragments. People are looking at different ways to conjugate, making it completely site-specific by engineering the antibody. So you've got sites that you can put the drug on. There are a lot of technologies to enable you to put large numbers of drugs, less potent drugs, on without changing the properties of the antibody. And indeed, a new field has emerged where people are adding different drugs, 2 drugs or 3 different drugs to the same antibody. In terms of the drugs, people are moving away from cytotoxic drugs and looking also at immune stimulating drugs, delivering those to stimulate the immune system in tumors, or to deliver agents that will degrade proteins in the tumor, or indeed delivering radioisotopes, which will then kill the tumor. And I think excitingly, the target is changing as well. The original idea was to target these antigens on the cell surface, but now there's a big field looking at targets within the tumor microenvironment rather than the tumor cells themselves. And I think what's also very exciting is that it's moving out of the oncology field as well. Antibody drug conjugates can deliver any agent that you attach to a cell by this mechanism. And in fact, people are looking at delivering antibiotics, antibody AACs, antibiotic conjugates, and that field is now rapidly emerging. And also there are targets within rheumatology, inflammation, and so on. So I've used up my time. I'll just leave you with my hero. My hero is Paul Ehrlich. He lived a long time ago. That's him on the left. He won the Nobel Prize in 1908. He was what we call the father of chemotherapy. He was the first person to give chemotherapy. And he was German, and he came up with this phrase, the magic bullet. We hear that phrase, delivering a magic bullet. And what he defined it as was a compound that could be selectively delivered to a designated target by another agent. What he's described is an ADC. So we like to think of them as going some way towards his vision of a magic bullet. So I'd just like to acknowledge a lot of people who are involved with these studies, and to thank you very much for your attention.
Thank you, John, for that wonderful presentation. Questions? Yes.
Good morning, everyone. My name is Debbie Nduta. I'm a postgraduate student in genetics. I'd love to firstly thank you for the wonderful presentation, Professor. I have two questions. The first one is, how exactly did you ensure the safety of your ADCs while you were still increasing the potency of that specific drug? The second question is, what are the fundamental differences between ADCs that target blood cancers and solid tumors?
Okay, so the first one was a toxicity question. Yes.
Yeah. How did you ensure that the ADC is safe while you are still increasing the potency of the PBD?
Okay, so yes, so that's a very good question. Of course, safety, what we're trying to do is widen the therapeutic index, and the safety is a very critical component of that. So there's a number of things that you could do, and of course, one of the most important considerations, particularly if you're using very, very toxic agents, is what your target is. Because if your target is expressed on normal tissue, even if it's at a much lower extent than on the tumor, then you're likely to deliver some ADC to the normal tissue, and that can have toxic effects. So, for example, I showed you the example of the HER2 and Herceptin, and then those ADCs, and they've been very, very effective. And they're not delivering very, very potent ADCs. We made an ADC targeting one of our very potent ADCs, one of our very potent warheads, to HER2 as well. And it was very, very good preclinically, but in the clinic, there was too much toxicity. And the reason there was too much toxicity is because HER2 is expressed on some normal tissue. So, and it's important normal tissue. It's expressed in the heart, for example. So, whereas the ADCs with the very, very potent warheads that work very, very well are targets that either are not expressed in normal tissue, or if they are, it's not critical tissue. Now, our drug, Zynlonta, that targets CD19, the target is on lymphomas, and they express it very highly, but it's also on normal B cells. And those are also attacked by the ADC, but that doesn't matter, because when you deplete your B cells, they can recover again. So that's an acceptable normal tissue that expresses the antigen. So you have to choose that very, very carefully. So for some targets, you need less potent warheads. And then your other question was about the hematological versus the solid tumors. Yes, I mean, the main consideration there with the solid tumors is that often the antigens are expressed at a lower level than some of the antigens on hematological cancers. But also, you get a lot more heterogeneity. In the CD19 expressing lymphomas, all the cells express CD19. And that's why you can wipe them all out. In a solid tumor, you very often get some cells that are highly expressing HER2, but adjacent cells may have different levels of HER2, and indeed some of the cancer cells may not express HER2. So you need to have that bystander effect. Does that make sense?
Okay, next question. There's Alicia there.
Thanks so much, Professor, for the kind of work you're doing. You seems to be ahead of time if it were not for the case of tumor mutations. I'm here.
Oh, I'm sorry, I couldn't see you.
It's great. So I have two questions. So the first one is because solid tumors keep shifting the goalpost, how is this your fancy technology sort of try to meet this because of, like you just mentioned, about heterogeneity within the tumors. So how is this kind of technology, which seems to be very expensive, adapting to the tumor mutations? That is the first one. Second question. So you mentioned about the hematological cancers. So how does the kind of work that you did in that product, how does it go well with the minimal residual disease? Like, such that we are not able to have the cancer cells reactivate back into the circulation of the cancer patients.
Okay, so the first question was about when solid tumors evolve and mutate and so on. Yes, so, well, that's obviously a good question. And the issue there is, you know, when those tumors evolve, does it change the expression of the antigen that you're targeting? And so the tumor can change, but also cells can become resistant to a particular therapy. And in fact, to CD19, cells can become resistant by down-regulating the expression of that on the surface. So, I mean, the first thing is that the potential is there to completely eradicate the tumor with an ADC. And if that's the case, then, you know, you don't need to worry about the tumor evolving. But if that's not the case, then you can, and there are a lot of studies now that have shown that you can then target a different antigen on the tumors with another ADC that has not been downregulated. So you can use combinations. And in fact, you know, as I showed a combination study that was with a BiTE antibody, not with another ADC, but with the right combination, you can hopefully get to the point where you can have a complete response. And what was the other question? Oh, hematological. Yes, and it's about minimal residual disease. Yes. So that's not been studied in great detail, but we do know that the ADCs stay in circulation for many days, if not weeks, and they can mop up a lot of residual cells, but also you can retreat down the road, even if you can't detect minimal residual disease. giving the antibody on another cycle can hopefully eradicate that. And there are some studies showing that you can reduce the level of minimal residual disease. Does that answer your question? Okay.
Yes. Please, just ask one question because I know there are a lot of answers. Just one. The rest we can meet during lunch and other breaks.
Thank you so much, Prof. That is some wonderful work.
Yes.
My name is Rebecca. Most of the questions I had have been asked, but at least I would like you to comment on, given that it is an antibody-based drug delivery, I would like you to comment on immunogenicity and how did you stabilize the drug that it wasn't degraded in circulation? Kindly, thank you.
Sorry, I didn't quite catch how did I stabilize?
That how did you ensure that the drug was not cleared or rather degraded in circulation?
Okay. I mean, we just knew from pharmacokinetic studies that if you have a non-cleavable linker, it's very, very stable, and you don't get any loss of the drug in circulation. With the drug linkers that we have that are cleavable, they've been optimized to be stable until they're cleaved. So actually, we've done in the clinic very extensive pharmacokinetic studies, and the ADC has our drug that's licensed has a half-life of about 11 days, and we don't detect any free drug in the circulation during that time. So we think it is stable, and it's not releasing the drugs. We do know that there can be some release in the tumor microenvironment because there are some cathepsins that are in the tumor microenvironment, but we haven't seen any release just in the circulation. Does that answer your question? Obviously not. Well, let's talk about it later.
Okay, my name is Philip Ogola. My background is in medical biochemistry. I was actually intrigued with the slides on the future of ADCs, especially looking at the radioisotopes, how it is incorporated in there. So my only thinking, or maybe you can comment on this, how does it stay bound in the human body? Because now you're dealing with radiation exposure. So how do we ensure that it is only specific to the cancer cells and this radiation is not exposed to the healthy cells based on the radiation protection principles? Maybe you can comment on that, or we can discuss it further.
Yes. So, I mean, there are two ways that you can attach radioisotopes to ADCs. One is in the way that I've described, so that it's cleaved inside the cell, and then the radioisotope is there intracellularly to damage the cell. But the other thing that you can do is with radioisotope, you don't necessarily need to internalize into the cell. So you could have a non-cleavable linker, or indeed use an antibody that's not internalizing, that just takes it to the surface of the cell and binds, and so the radiation is then there at the tumor. So there are two approaches that you can use with radiation, whereas with the drugs, you don't want the drug necessarily released outside the cell, you want it inside. But with the radiation, depending on the path length of the radiation, then you could attach it to the surface of the cell, and actually you would then get a bystander effect as well, locally. But it may depend on what isotope you use, the path length of the radiation damage would determine how much normal tissue damage you would get.
Okay, one more question. There was one question, somebody wanted to ask a question on that end. So
Yes.
Caroline?
Thank you, Prof, for the good presentation. A quick one. Do you anticipate any shift towards antibody conjugated nanoparticles and also embracing active compounds which are plant derived?
Sorry, I didn't. Do I anticipate?
A shift towards antibody conjugated nanoparticles and incorporating active compounds which are plant derived.
So antibody conjugated nanoparticles.
Nanoparticles. Yes. Okay, sorry, that's the bit I missed. That's a different field. I mean, I know there's a lot of work going on in nanoparticles, and particularly those with antibodies, so that they target to specific antigens. So I think that they're not as advanced. And so I don't know that I can answer that, whether they're going to be as effective. Do you know? Have you had any experience? No? Okay. So I'm not sure I can answer that one. I'm sorry.
All right. So, so we'll have 2 more questions because we are also running out of time. So Lucas and then 1 more person. And then we take the discussion personally to John. I think he is still around so he can answer all your burning questions.
Good morning, sir. My name is Dr. Lucas Nabero, and I have a question about genetics. So ADCs seem to have serious adverse effects. For example, in HER2, ILD, interstitial lung disease, and other things. Is there a genetic predisposition of the patients who seem to get these serious adverse effects? And is there a way we can pick out patients who we think are going to have the adverse effects using genetics?
That's a very good question. And those ADCs that do have the side effects, it tends to be mostly related to the warhead, to the drug, rather than target related. So in that case, the type of toxicity, as I say, is related to the drug. So it would depend on what is known about the profile of that drug and whether there are biomarkers for particular types of agent or particular types of toxicity. So yeah, I think it's a complex question. We can maybe discuss it more over a coffee. But I think the simple answer is I don't know anything specifically, but I know that there are certain types of toxicity with some ADCs, such as ocular toxicity or some skin toxicities, where I think that there are biomarkers emerging for early detection of those side effects. But I think we need to understand more about the drugs that are being delivered, because they tend to be class effects. So ADCs that against different targets that target the same warhead tend to have similar toxicities. So it's more the warhead related than the actual target that's being bound by the antibody, if that makes sense.
Yeah, there was 1 more question there, and then we close, and then you can meet John later and ask all those questions.
Okay, so hey, Prof. My name is Joy Ogingo. Mine is not really a clinical question, but just a concern. So you find most of the times immunotherapy is relatively expensive as compared to chemotherapy. So I'm just concerned, is there any way that agencies like yours are working together to maybe partner with government institutions or non-profit organizations to make immune-targeted therapies more available to especially people in lower middle-income countries in rural areas?
Yeah, of course, that's a very, very good question. Yes, I mean, a lot of these agents are being developed by big drug companies. Some of the indications are relatively small, and as a result of that, they can be very expensive therapies. But I do know that as these drugs are becoming more widely used and rolled out different continents across the globe, that there are now attempts to bring the prices down. And indeed, as there is more competition, the prices will come down. I can only speak for the company that I'm involved with that licensed Zenlonta. That is now, it's approved in America and in Europe, and it's now going to be approved in Asia and beyond. And they are working very, very hard to make sure that there is access worldwide as the drug is rolled out. And I know that they are already talking to government agencies about being able to in countries such as Kenya, being able to have this drug available. But that won't happen overnight, unfortunately. It'll be down the road. But I know that some of those discussions are being had.
Okay, thank you, John. Let's appreciate him once again. So there are a lot of questions, so we've really gone over time. So I would suggest that we all go downstairs to the front of the building to take a group picture. And while we are down there, we can then go to the exhibition booths. Afterwards, we'll go for lunch and come back at 2 for the afternoon session. And I'll guide you accordingly. So in order not to waste more time, let's just go to the front of the building, all of us, to take a picture. This picture because you were registered for the conference. So I'll email this group picture to all of you. So let's do that as soon as possible. Thank you.
Sinamaliza corazón. Matusi meiona basata wakinifungia serufi zinazopata mia filmia mjusi ukuta wa parasta na uparamia na kama penzi
The Nova Seed X series scales with you. Powered by XLEAP SBS chemistry, our fastest, highest quality, and most robust sequencing by synthesis chemistry to date. XLEAP SBS nucleotides use a novel improved block and linker, and a new polymerase engineered to incorporate nucleotides faster and with higher fidelity than ever before, delivering up to 2 times faster incorporation rates relative to standard SBS. XLEAP SBS chemistry also enables up to 3 times faster block cleavage, further improving cycle time. XLEAP nucleotides are more resistant to heat stress, 50 times more stable in solution, and 500 times more stable when lyophilized. The improved stability translates to fewer unblocked nucleotides after heat stress, enabling improved base calling accuracy and ambient temperature shipment of reagents. The NovaSeq X series allows your lab to shrink total cost of ownership with breakthrough innovations in chemistry, informatics, operational simplicity, and streamlined workflows. The workflow has been optimized to minimize time and labor. The NovaSeq X series incorporates thoughtful ergonomic design and usability innovations such as extra-large 4K resolution touchscreen to clearly view run progress and performance metrics, lightweight reagents, buffer cartridges, and waste containers that are easy to handle, user-specific safe settings for the adjustable screen and soft-close doors and drawers, individually addressable flow cell lanes with automatic library loading, automated onboard cluster generation and post-run wash, and touchless secondary analysis for key applications and more. Onboard Dragon speeds up computing and features built-in lossless data compression, with easier and faster data transfer and management with automated compression of FASTQ files. A smaller data footprint also reduces storage and energy consumption costs. Plan your integrated Dragon analysis in the cloud or locally via Illumina Run Manager, or utilize the 4K touchscreen. Select multiple simultaneous analyses per flow cell, including BCL to FASTQ conversion and application-specific analyses. Reports will be accessible on instrument for onboard analysis. The NovaSeq X and NovaSeq X Plus systems were purposefully designed to reduce environmental impact. The improved robustness and stability of reagents, including several in lyophilized format, allows for shipping at ambient temperature, resulting in less waste and elimination of dry ice. Remarkable benefits are delivered through the cost and operational efficiencies enabled by a 90% reduction in packaging waste and weight, 50% reduction in cartridge volume, and the use of biopolymers and recyclable plastics. Handling is much easier with lightweight reagents, buffer cartridges, and waste containers. Load-and-go reagent cartridges feature thaw windows to visually verify that reagents have thawed completely. The system will lead you through the process of run preparation and reagent loading. The light bar and drawers will guide you through the steps. The instrument will check that all RFID-encoded reagents have been loaded properly. Sequencing will begin after pre-run checks, minimizing the chance of user error and ensuring compatibility of reagents. Monitor the progress of your sequencing run and view detailed performance metrics from the instrument or via the cloud. With substantial application breadth and revolutionary performance, the NovaSeq X series redefines the limits of high-throughput sequencing to propel genomics research forward. Beyond the significant reduction in cost per gigabase, the NovaSeq X series incorporates cost efficiency throughout the workflow, including operational simplicity, integrated data analysis, sustainability advancements, and world-class support. You are ready to change the world. With the NovaSeq X series, you can.
Akiso. I am a PhD student here at CAVI, a PhD in immunology. So CAVI generally is an institute that does a lot of clinical trials for HIV vaccines, trials, and other infectious diseases. And we also do a lot of basic research work, all to inform on how to come up with effective vaccines for different infectious diseases. And my work mostly tries to understand the female genital tract, because the female genital tract plays an important role in women's health. For example, in HIV transmission, studies have shown that women are at a higher risk of HIV acquisition as opposed to men. And this has been linked to the female genital tract structure, first of all. And that's why I'm more interested in understanding the female genital tract, because it plays an important role in women's health. And also in things like pregnancy outcomes, the female genital tract plays a very critical role. And that's why I decided to do a project focusing on women's health, particularly focusing on the female genital tract. So my study tries to understand how alterations or how different microbial communities in different women might affect the integrity of the vaginal secretions, which form the first line of defense upon exposure to any pathogens. And in terms of next generation sequencing, so like now I use the MySec I100 for the sequencing. So that one helps me to be able to at least know the different communities that I have in these samples. And then the beauty with the MySec I100 instrument, the cartridges come at room temperature, so I don't have to do the thawing bit, which I would have done with the old MySec. So I just have the cartridges in my packaging and then remove them. The most important thing to note is that you only have to open that pack within 4 hours. So you have to make sure you don't open it earlier. So once I open the cartridge, I just need to load in my sample that I've brought to 60 picomolar, and then I put it into the machine. So with the MySec I100, the process has been shortened and it's like very easy, straightforward to do. And also the data acquisition, it takes shorter time, maximum of 15 hours, unlike the old MySec where it will take like 48 hours. Adopting the MySec I100 in this lab will definitely improve the research work here. First of all, for example, for the old MySec, we could only do 1 run per week, because, given the time it takes to give out data. So we could only plan 1 assay per week. But given the new MySec I100 that only takes 15 hours, we can do even up to 3 assays in a week. And then also the quality of the reads you get with the MySec I100 are more. And this translates to better data and therefore better clinical results that you can give out to the patients out there. I think we are heading into the right direction, because first of all, we are going to be getting quality data which translates to like quality implementation into the society. And also I think we are going to have like more knowledge comparable like to the Western countries that have always been known to be doing more of this next generation sequencing. Like previously, you'll find most of the samples will be sent outside for sequencing. But now with these new technologies coming in, like the MySec I100 from Illumina, which has a very straightforward process, like anybody, so long as you have the protocol, you can follow it. So I see most of like us researchers in Kenya being able to do quality next generation sequencing work and producing quality data that is going to improve generally our health. I'll just encourage our researchers not to be afraid to do such work, because it's possible, and we have the technology, we have the instruments, and we have the support from the companies. You know, in case you are stuck anywhere, it's just a phone call away, and they will come and give you the necessary support that you need.
Before 1986, the isolation of genetic information was a very time-consuming, complicated, and dangerous process. The DNA within a biological sample had to be separated from all other molecules in various steps, often with uncertain results. With the introduction of the kit concept, QIAGEN furthered the revolution of molecular biology. The extraction of small, circular DNA molecules found in bacteria cells now takes only 2 hours. The introduction of the first generation of kits, which contained all components needed for the isolation of genetic material, just like the current products, is considered a cornerstone of QIAGEN's success. By comparing the different methods, one can see just how revolutionary QIAGEN's development was. The traditional method consisted of many single steps. The stabilization, purification, and processing of a sample would therefore take up to 3 days and was not highly reproducible. QIAGEN's kits, however, made the same process shorter, safer, and more efficient, also providing significantly better results. The kit concept was the first of many other innovations to follow that standardized laboratory work and paved the way for further dissemination of molecular biology. Today, QIAGEN also offers automation of entire workflows, from sample to result, such as the QIAsymphony RGQ platform. Today, the company is a technology and market leader in all areas in which sample and assay technologies are used. From molecular diagnostics to academic research and the pharmaceutical industry to applied testing, which includes veterinary medicine, food safety testing, and forensics. QIAGEN, making improvements in life possible.
Hi, my name is Florentin Sandwald and I am an application specialist here at QIAGEN in Hilden. And I'm here today to show you how it is to have an Easy2Connect in your lab. The Easy2Connect is a nucleic acid purification instrument. But it does not just automate some parts of your workflow, it automates everything from lysis to elution. So let's go purify some nucleic acids. For this demo, I will use formalin-fixed paraffin-embedded tissue sample, or short, FFPE. If you are familiar with this kind of sample, you know how hard it can be to get nucleic acids from these. There are usually many steps necessary, so automation is very challenging. For our FFPE samples, I will use the EZ1 and 2 DNA FFPE kit. It's named this way because you can not only use it on our Easy2Connect, but also on the EZ1 Advanced XL. The EZ1 and 2 DNA FFPE kit comes with everything you need to treat your sample. Buffers, solution, tip holders, filter tips, tubes, and the already pre-filled ready-to-use cartridges. So the time you need to prepare your sample is drastically cut down. So my first step is to add paraffin removal solution to the tube that has my sample. Now I put the tube into the heater to heat it up to 80 degrees for 2 minutes. Here's a sample that I've already heated. Now I can open the tube and put it into our instrument. The Easy2Connect can treat up to 24 samples at the same time. On the display, I can select my sample type and the kit I want to use. Now every protocol that is available with this kit is shown. So I pick my protocol, and in the next step I can define my elution volume. So this is fine. In this screen we select our sample position. We positioned our sample in row 12. So I can select a single row, I can select multiple rows, and I can select all rows at once. But let's stick with row 12. In the next screen, we see our sample IDs. We can rename them, or the Easy2Connect will also auto-generate sample IDs. You can add additional nodes to the samples if you have anything to mention. Now we are going over to load the racks. First, we are going to load the cartridge rack. For this, we take one of our cartridges, invert it a couple of times so the magnetic particles are mixed, and then we can put it into our rack in the position we defined. Now You put the cartridge track back into the device. The last step shows us how to load our tip rack. So take a tip holder and the tip, and we put it in row C. So I take an elution tube, remove the cap, and I put it in row D. Our sample is already in row A. If you are unsure, you can just click on the positions and the instrument will highlight which labware goes in which row. So now we are done. We can close the hood and click on Next. Now we get a short summary of our run setup. If everything is fine, we can just click Start. Now here's where the magic happens. Unlike other benchtop instruments of this size, the Easy2Connect is equipped with everything that you need to generate a maximum degree of automation. It pierces the cartridges itself inside of the instrument and uses pipetting tips to transfer liquids and magnetic beads inside of the liquids. A strong magnet bar is used to hold the beads inside of the tip. This is one of the features that makes this instrument so special. While conventional approaches only allow to transfer beads from well to well, the Easy2Connect can also transfer liquids. This allows the automation of work steps like adding enzymes or solutions. The Easy2Connect can heat up samples, so protocol steps with heat incubation can be automated, or work steps can be optimized by applying a certain temperature. Now, let's look at some other kits you can use with the Easy2Connect. Here is the Easy1 and 2 CCF DNA kit. You can use this kit to purify cell-free DNA from up to 8 milliliters of plasma. Then there's the Easy1 and 2 DNA tissue kit. This kit isolates DNA from virtually every common type of tissue. To isolate gDNA from 200 or 350 microliters of blood, the Easy1 and 2 DNA blood kit is the optimal solution. The Easy1 Virus Mini Kit version 2 isolates viral DNA and RNA regardless of sample type, whether serum, plasma, cerebrospinal fluid, urine, respiratory samples, or other cell-free body fluids. If you want to isolate RNA, the Easy1 and 2 RNA Tissue Mini Kit is the kit you need. If your sample type is not addressed by these kits, remember that QIAGEN has also other kits and is always inventing new solutions for you. The actual progress of your protocol is shown on the right side on the display, so you are informed about the ongoing all the time. You could also leave the lab and monitor your run progress from outside. You can do this by installing the MyQIAsphere app on your preferred mobile device, or by using the MyQIAGEN internet widget on your laptops or desktop PCs, just by using your MyQIAGEN account. Once the run is complete, just open the hood, grab your tip rack at both sides, and put it gently outside of the machine. Then you do the same for the cartridge rack. Close the hood and click on Finish. And now, here's your elution with high-quality nucleic acids isolated from your sample with just using very few manual steps. If you want to try out the instrument inside of your own lab, the QIAGEN sales team is more than happy to help you. Call us now and experience the Easy2Connect in your own lab. And I'm sure you will find it easy too.
QIAGEN. Sample to inside.
For years, Pathologists Lancet Kenya has been at the forefront of medical diagnostic in Kenya, providing accurate and reliable results. Now, we are embarking on an exciting new chapter. We are now continuing our journey as Saba Lancet Kenya, your trusted partner for medical diagnostic, and will be strengthening our presence and expertise in Kenya while remaining a strategic hub for our subsidiaries in the East Africa region. Operating in 15 counties, all our laboratories are led by a team of board-certified pathologists. As Saba-Lancet Kenya, we proudly hold ISO 15189 accreditation. We utilize cutting-edge diagnostic tools and streamlined processes to deliver fast and accurate results. As part of Saba-Lancet Africa, you will have access to a comprehensive range of services, including over 4,000 tests, from routine checkups to specialized diagnosis, and giving you access to a wealth of skills, expertise, and resources, making us a global healthcare provider and allowing us to remain at the forefront of medical advancements. At Saba-Lancet Kenya, we are committed to providing you with world-class medical diagnostic closer to home. Welcome to a new era of healthcare excellence.
When your business story reaches global markets, we have the world-class risk mitigation tools to help you thrive through the turbulence. At ABSA Corporate and Investment Banking, we are invested in your story, and we invite you to write it with us because your story matters. ABSA.
I want to talk about sickle cell and blood donation awareness, which is one of AFUC's projects aimed at creating awareness about the disease and its prevalence in the UK. So sickle cell is a genetic blood disorder that affects the red blood cells. So ordinarily, every healthy red blood cell is supposed to be in a circle, but when you have this disorder, your red blood cells, or many of your red blood cells, deform into a crescent kind of shape, and that affects the air that is supposed to go in and out of your red blood cells to get you to generate blood. What happens is that this is a genetic condition, and it's not curable, but it's manageable. People who have this kind of condition suffer a lot because our very existence depends on the blood flow. And so if you have issues with how blood flows, then you have question of life sustainability. And so what it is now is that it's on the very high increase in the UK. 3,000 births every year. Babies are born with this kind of disorder. Unfortunately, a majority of them are children who come from the black mixed race heritages. One of the ways that this condition is managed is through blood transfusion, regular blood transfusion. NHS has reported that there's a shortage because they do not have high numbers of people from the black, Caribbean, mixed heritages donating blood. And so that's why AFUC has jumped on board this campaign to speak out to people in our community so that we are aware that this is the need for our brothers and sisters who unfortunately have this disorder, and then we can spread the news and possibly get as many more people to donate to the blood bank. So this afternoon, if you haven't heard this message, this is the message that is going on, and we are honing it so high and loud in the UK so that we can get people to donate to this worthy cause. If you want to donate, or you've spoken to someone and they want to donate, you can speak to us and we will guide you to register as a blood donor. Or if you want to also have a presentation or a talk at your organization so that you can help in creating the awareness, please get in touch with us. We will be there with our team and to give you the necessary information to help this worthy cause. Thank you very much.
In agribusiness, movement is everything. One delivery late, one big buyer waiting to pay, and the whole trade cycle feels like it's on hold. Agri-trade financing is a way to align capital with how agribusinesses operate. Most agri-SMEs experience cash flow gaps. That gap creates pressure. Pesa imeshikiliwa, biashara imesimama. Agri-trade financing focuses on timing. It gives working capital that moves with your sales cycle. It's not about more debt, it's about capital inapohitajika to unlock growth and meet demand. So who qualifies? You are an agri-SME, a stockist, trader, processor, or buyer who needs working capital to boost stock and purchasing capacity. You've been operating for more than 12 months, making a minimum of 300,000 Kenya shillings monthly, even if you're unregistered, as long as you have county permits. We solve the pressure created by cash flow gaps. Agri-SMEs often have a cash gap between purchasing stock and getting paid. You buy, transport, and deliver, but the money follows later. Or you need to restock, but the money is short. That delay slows everything down. Biashara inasonga, lakini pesa haizunguki. Avenues gives you control over when capital enters the business. Why does this matter? Agribusinesses don't fail for lack of sales. They fail because cash gets stuck. Biashara iko, lakini pesa haiko. Avenues fixes that by moving capital with your trade cycle. Access when needed, repayment from revenue, and automatic credit refresh after each repayment. Avenues financing enters where trade slows, when stock is low, cash is locked, and payment is late. It's not about more credit, it's about capital that arrives when it counts. Apply now through Avenues website.
This is an academic center that brings a lot of researchers together who work on different topics on cancer, because every day we realize that cancer is not a single disease. It's a complex disease, and it has got many phases. So you can't understand this disease if only one person is working on it. So you have, and then you have many cancers, which affects almost every organ of the body. So all these researchers come together. They share resources. This would be like, machinery, core facility expertise, but then they try to study different aspects of particular cancers. For instance, you have in my lab group or in my research group, we look at something called metastasis. So metastasis is when cancer spreads to a different organ from the primary organ. And if you're a breast cancer patient, for instance, you can have metastasis to the brain, to the bones, to the liver, to the lungs. So metastasis that goes to the bones or to the lungs, they're totally different. You can't treat them in the same way. So the reason why we do this is we try to understand the molecular mechanisms behind these different spreads, and how can we then maybe make drugs that can specifically treat metastasis to the lungs, which is different from the one to the liver or to the bones or to the brain. So that's, in a nutshell, what we do.
That's what you do.
Yes.
In
But
Denmark.
specifically myself, I'm more interested in the vascular system, because cancer requires the blood system to travel to these distant sites. So I'm trying to understand, how do these cells communicate to the blood system, and how does the blood system communicate back to the cancer cells, telling it that you have arrived at your destination, because they just don't leave the breast and just travel anyhow to the bone. Something is directing them, and there are signaling molecules within the blood system that actually do this. So that's what I'm actually doing.
What have you found so far? What is it that directs them to the area where they end up?
There are a lot. There are a lot of things, and because we use cell line models. So if you use one cell line, you're going to find one particular molecule. But because patients are different, so we try to use a simple cell model to understand this. Then we go into patient samples, and then we try to extrapolate whether the same molecule that we saw in our cell systems, we can then find them either in the blood, urine, or spinal fluid of patients. So right now, my preliminary results, I've found something called growth factors. So these are factors that they help with the survival of the cancer cells as they travel. And so what I need to now find out is whether these cancer cells actually express receptors for these growth factors that I found. Because if they don't express the receptors for these growth factors, then it's not what I'm looking for. So this is now the molecular aspect of it, because if you are to make a drug to target this growth factor or the receptor, you actually need to understand whether they actually interact, form this lock and key that then tells the cancer cell you've arrived in the lung, or you've arrived in the brain, or you've arrived in the bone. And then you can now start colonizing this new environment, which then forms a metastasis.
Where does it begin? Where does this cancer cell begin its journey from?
The current dogma is that it's mutations. Yeah, so when you have a lot of mutations, when the cells are dividing, of course, it's like a tear and wear process, because the DNA is unwinding and then closing during the cell division process. So during this process of unwinding and closing, sometimes there's a mistake. And if these mistakes accumulate, then they form a mutation. And if the mutation hits a target that is responsible for checking the integrity of the cell, then it means that the cells can just grow and the integrity is not checked. So then they become cancerous. Yes.
So because there's no, if we can just, because I mean, it can, we're getting down to the nitty gritty, isn't it? Yes. That's what molecules are. Yes. I'm just remembering from biology days, you're looking at the minute thing.
Yeah.
And if you can look at what then is domiciled there, then it can give rise to, bigger answers.
Yes.
But what's the end goal here with this molecular research? For treatment or for cure from where you are? Because you've mentioned, okay, so there are growth factors here. Can we then start to look at the science behind creating a drug that will treat this particular kind of cancer You talked about having an interest in the vascular
system. Yeah.
In the vascular system. So are we looking towards cure or are we looking towards treatment? And does that treatment then get applied across stages of cancer, 2, 3, 4?
Yes. So ideally, we want to find a cure. And from my perspective, I always say the cure for cancer is surgery. If we can remove the cancer fully from the organ it's attacking, and then there are no margins left, then we can tell the patient, we think you're cured. But cancer is a complex story. I've been in the field now for 12 years. Right from my master's degree now to where I'm doing my research fellowship, it's been 12 years of a journey. I think it's a very, very complex thing, because the more we learn about it, the more we find out that there's something behind something. There's a story behind a story. But back to your point, yes, the goal of molecular cancer research is to develop therapies, because that's what we can do. Yeah. If you look at all the therapies that we use on our patients right now, somebody somewhere is sitting in a lab working on it, trying to understand the disease at a molecular level, then designing a target, either a chemical inhibitor or an antibody or something we call an antibody drug conjugate that can stop that cancer. And I don't think we are doing that enough in this country. Yes.
Why? What's hindering us?
We are not investing enough in cancer research. Do you know that since 1963, the first time we had a research call for cancer in this country was during the COVID era, and the government only set 50 million shillings aside for it. I know this because I'm one of the people who applied for it. I was still based at Yale University then, and of course, government bureaucracy, things take long. So all these projects were then combined into bigger projects, and some funding was issued. But that's it, 50 million shillings. That's like nothing. You can't solve this menace with 50 million shillings.
So, okay.
In research, success isn't just about the number of mentions, it's about connecting with the right people in the most effective way. Without context, simple counts can be misleading. It can be difficult to fully understand how your research is resonating with your audience. Altmetric's new sentiment analysis tool changes that. It analyzes sentiment behind online mentions of your research on various social media platforms, showing whether the conversation is positive, neutral, or negative. In minutes, you can uncover how your work is being received, benchmark performance, and make confident, data-driven decisions. Move beyond counting mentions and understand the true value, influence, and engagement of your research. Start exploring sentiment analysis with Altmetric today. Visit altmetric.com to learn more or book a demo.
Yeah.
And yet we have many cancer researchers who are Kenyan.
Yes.
Where are they operating from?
A lot of them are abroad. In different countries, I know, because even some of the people that we founded that organization with, the Cancer Research Foundation or the Integrated Cancer Research Foundation, they're Kenyans. The CEO of this organization is called Dr. Hudson Alakonya. He's now based at Cold Springs Harbor in New York. He's trying to image pancreatic cancer, because pancreatic cancer is one of these cancers that hides. And only through imaging can you find where it is. That's what he's trying to do. We have one called Dr. Fiona Okonjo, who is in England. He's working for a company there. We have a Kenyan called Dr. Francis Makoa, who is really trying to push the limits. He's doing a lot of genomics work, but there's no funding. There is no money. And you cannot win this war without investment in research.
There's no money where? Because there's money where the researchers are currently.
Yes.
So let's look at it from a burden perspective.
Yes.
Where the cancer burden in Kenya today is quite something. I mean, the numbers that we're looking at in 2023 are incomparable to what was happening 10 to 15 years ago.
Yeah.
Right? Yeah. So 2020, 2019 is when we started to see a lot more cancer cases result in death. And maybe that's where the call came for something to be done. There's a lot of theory around that. So for a place where the burden has multiplied in the manner in which it has, one would think that the next thing would be, well, come on, guys, we need to put some money and might behind this thing to find out exactly what is happening. In the world of science, what comes first? Do you wait for the burden to be so much so that you say, oh, okay, we need to throw something behind it? Or do you say, actually, you know what? It's important for us to do this research anyway, and let's find out exactly what is going on.
I think it can cut both ways. For example, in Denmark, where I am, this last year, which was 2022, I think they gave about $1 billion in research funding. This is to different areas. I think life sciences gets about 50% of that. And half of that then goes to something called basic research, because it's basic research where innovations come from. It's basic research that helps you understand things. And then there's applied research where, we've developed a drug, but now we want to take it into the clinic. So now you start studying this drug in patients, in animals, and then maybe you want to do a regulatory approval, and so on and so forth. But basic research is really the fundamental that drives these countries, because when they understand the disease at that level, then they are able to identify there is this target, there is this target, there is this target, and then the government comes in and says, okay, we know that this research group has identified this target, this research group has identified this target. Can we then give money as grants so that this can be developed into a drug or an antibody? And then once this passes successfully in clinical trials, then the whole world is their market.
So there needs to be a constant...
Exactly.
There has to be constant research, constant search for knowledge. You don't want to wait until something has progressed to a certain point before you now start saying, put the money behind it. Okay.
And if I just go back a little bit, I think last week Citizen TV was talking about the big conversations about cancer. And I listened to it. It was around 3 hours. I listened to it fully. And of course, a diagnosis, therapy, advocacy, all these things are important. But you barely hear research. We don't talk about it. And we need to start telling patients that the reason why your medicine is expensive, the reason why your diagnosis is expensive, is because all the antibodies we are using for immunohistochemistry, for instance, all the drugs we are using to treat you, they are imported. Sometimes they have to come in cold temperatures. That's cost of flight. If it's stuck somewhere, somebody has to pay for that cost. And who is going to pay for it? It's the patient here. So if we start developing our molecular research here, then some of these things we can make them here, because Kenya has got enough talent to do these things here. I would say I'm a living example, but I also know so many people across the world who are Kenyans, who are working in different labs across the world trying to do research on cancer. If only they could get funding from the government, because the government has to put funding first before the private sector comes in.
Is that what happens globally?
Yes.
Is research government funded?
Yes.
In Denmark, where you work, how much of government funding goes into research?
So last year, the government of Denmark set aside $1 billion to fund research initiatives in the country. Once they put this money, then other philanthropists, the big pharmaceuticals in that country, like Novo Nordisk and Novozymes, Leo Pharmaceuticals, Lundbeck Foundation, they then follow that up, because the government is putting...
The government is signaling that this is the way to go.
Because remember, a private company doesn't want to pay for overheads. So the government will pay for that. A private company wants to buy you research consumables because they want output. So if the government pays salaries, and sets up the labs, then it's easier to walk into a foundation and tell them, look, we have a functioning lab. What we are missing is some money to buy some reagents and do ABCD.
So $1 billion from Denmark into research.
Into research.
What's the total budget of Denmark in dollars?
I don't have that in mind, but it's huge. It's huge. And again, this year in their finance bill, they're proposing to increase that to around $2 billion in research.
Just going into research?
Yes.
In all forms of research?
All forms of research, not just biological or biomedical research, all forms of research. And to just tell you how they are earning from this. So in 2006, in terms of life science industry exports, Denmark earned 58 billion DKK. So if you multiply that by 20, that's around 1 trillion Kenya shillings. Yeah. In 2018, it was 115 billion DKK.
Their earnings.
That's their earning from product exports, from the life
pharmaceutical product export.
Exactly. Yeah.
And this is now basically what you're saying is that research of $1 billion is earning them a lot more.
It's earning them a lot more.
In terms of how much then they're able to produce in the country and then to export.
Yes. In 2020, it earned them 151 billion DKK. That's essentially what we collect all here in taxes. They earned just from the pharmaceutical industry. And it's because there's a massive pipeline of startups that start from university labs doing molecular research on different diseases, cancer, diabetes. I don't know, I know you guys follow world news. You heard of this weight loss drug that came from Novo Nordisk.
Yes.
How much money do you think they're going to earn from that? It's going to be trillions of dollars.
Oh yeah, $80 a pop, that's for sure. Yeah.
So somebody somewhere sat down, spent 10 years of their life doing that, and now they'll just be resting at home, earning money from that, from all over the world. And Kenya being a leader in East Africa, if we take these things seriously, there's just a market around us. There's a big market around us because our genetics is so similar. So whatever will treat Kenyan patients will most likely treat Ugandan patients, Tanzanian patients, South Sudan, DRC, Rwanda, Somalia, etc.
Victor Oginga Orie is a lead research fellow at the Biotech Research and Innovation Center in Copenhagen, and he's a chief scientist at the Integrated Cancer Research Foundation of Kenya. Now, tell us about this foundation.
Okay, so this foundation started in 2018. It was an idea born by Dr. Hudson Alakonyo, who is our CEO, and it's because he saw the burden in the country, but he saw nothing concrete going towards addressing this problem. All other things were reactionary. Let's do diagnosis, let's do treatment, but I always say, you cannot treat what you don't know. You have to understand what you're treating for it to be effective. So Hudson, back then he was at Oxford University. So that's where he met certain friends. Some were Kenyan, so some are from Europe. And they came up with this idea. And we met on LinkedIn because Kenyans who've done cancer biology as a postgraduate study are very few. So he reached out to me, and he just, we just clicked because I also had the same idea that it's important that we have a conversation about cancer research in Kenya. And so our ideas merged, and this is how Cancer Research Kenya was born. So we were fully registered in 2021 by the government of Kenya. So we are a non-profit by guarantee research organization. And actually this week we have a symposium at Kenyatta University on molecular cancer research, and it's going to start tomorrow until Friday, and we have exciting talks and speakers. It's the first event we are having on site, but we've also done a number of events. We've done awareness sessions, but in a different way, based on science. Yeah, because sometimes you come across documents or publications, someone says, if you eat hot ugali, you get breast cancer.
Yeah.
I mean, I don't see
cancer.
any correlation between cancer and eating hot ugali. Yeah. So I think it's important that even as we tackle this menace, it's important for people to also get the right information.
Address the myths.
Exactly. Yeah.
This is major. Because I believe at some point we had a conversation about, health interventions that take place because of myths. And this particular story that we're talking about, the link, especially in a certain region of Kenya, we're talking about the link between drinking hot beverages and esophageal cancer. And it came from a medical practitioner.
Yeah.
Right?
Yeah.
And even as now we are talking about molecular science and how it can then have a link towards treatment because of the way in which health affects people. The person who sits on the other side of the desk or the other side of the glass and is a health practitioner is going to be believed.
Yes.
It's your pastor, it's your doctor, it's your teacher. Those are the three people that you take, leading from.
Yeah.
So when you say this and we talk about things now that people have started to do as a result of that information, then are we not looking at a situation that is then damaging when it comes to, things that people have done over time? So maybe somebody does have esophageal cancer and other people stop drinking hot beverages and there could be something else that is the link towards this disease.
Exactly. There is an underlying genetic mechanism behind every cancer. There is an underlying genetic mechanism. I can assure you of that. And until and unless we find it, we can never treat it. If you look even at Meru County, there was a publication that came out, I think, maybe in 2018, and they were looking at the burden of cancer in Meru County, and they found out that stomach cancer had the highest burden comparable to countries like Japan, which also have the highest burden. And they say that because of chewing miraa could have caused this. But then I tell myself, there are people who chew miraa and don't get this cancer. There are people who don't chew miraa and get it. So it can't be miraa. This is just a coincidence. And I would say that there's a genetic effect. Maybe the Meru people have a mutation in a specific gene. There's a certain type of stomach cancer that is genetic. And so there's a mutation in a certain gene that they probably have. But because we've never screened them at that molecular level, we can never know the truth. And that's why we need to invest in these things. Then we can say people in Meru County have stomach cancer because of this particular mutation, or of this particular receptor, or of this particular enzyme, and so on and so forth.
So just for purposes of clarity, Doc, we are saying that there is a direct link between molecular science, what you're able to find on that very small detail, and treatment for cancer. We are saying that we can make a link.
Yes.
If we look at the science properly, not we, you, and others in the field, look at this science properly and make the linkages, then we can actually have treatment that is going to start to, obviously, work.
Yes.
Is that what we are saying?
Yes.
Unequivocally having been proved, or it's still in the process of being researched?
It has been proved. And let me give you examples. For instance, if you know of women, or if you've heard of women with breast cancer, you hear of HER2 positive breast cancer.
Yeah.
So HER2 is a receptor, and it is overexpressed on the surface of breast cancer. And so when you have more HER2 on the surface, it tells the cell, keep growing, keep dividing, keep growing, keep dividing, because there's a lot of it on the surface. So we developed an antibody that blocks that receptor and then tells the cells to stop growing. And that's what we use, the HER2 antibody. Is it called Herceptin? That's what it is. Somebody sat down and figured out that there's a particular type of breast cancer that overexpresses this, and then developed an antibody towards that. There are cancers that really rely heavily on blood vessel networks. And there's a growth factor called vascular endothelial growth factor. This is what communicates to the blood vessels and tells them to divide and spread. And cancers love when there's blood vessels around them, because then they get food, they get oxygen, and they're able to get the waste also outside of the cells. So a monoclonal antibody, or an antibody that blocks this receptor, was developed. So it means there's no communication between the ligand and the receptor, so the blood vessel cannot spread throughout the tumor. So the tumor is starved of food and oxygen.
Grow.
It shrinks. Yeah.
Okay.
Yeah. So, and this is very targeted. Yeah. It's very, very targeted. So you can only use it in a particular cancer after you've known that this is how it behaves. Yeah.
usually we adopt things, we adopt best practice that has started, you know, somewhere else, or somebody must have said, okay, this is good, it works. Can we now invite it? And then again, the scientists, the researchers look into it and they say, okay, let's see if we can bring it here. Let's look at the big 5 cancers in Kenya: breast cancer, cervical cancer, prostate cancer. We look at leukemia, bone marrow. There's one other I cannot remember.
I think it's esophageal cancer.
Yes. So, can we then say, if we're looking at adopting best practice, that this science or this research, can you pinpoint, or can we say that already this molecular science is looking at the growth factor in these big 5 that are in Kenya today, that make up 90% of the cancer burden for this country?
Yes. Yes, we can do that. But first, we must generate what we call cell models. So we need to work collaboratively, researchers with surgeons, with molecular oncologists, and so on, so that when they get that biopsy from the patient, if it's big enough, some of it goes to pathology, some of it goes to the lab, where I and other people can then make cell lines out of this, because a lot of times, drug development, we use cell lines from Caucasian patients that doesn't match ours. So the first big thing, and something that I would really want to see maybe our government through the NCI investing in, is we need to have a broad panel of different cell lines from across this country for all different types of tumors. Because then when they're doing clinical trials and drug testing, we can also say, okay, you want to sell that drug in Kenya here. Let's see if it can work in our patients. So if it's not working in our patients, then we have to see how it can be redesigned so that it can work. Or we can simply say, okay, it's not working for our patients. So now let's find out why our patients are different. And then can we develop our own here locally? It will be cheap in the long run for the patients. And this is something that I say it's investment for public good. We don't do this for profit or anything. It's a tireless work. And you're doing it for public good.
So let me get it right, Victor. You're advocating molecular cancer research. As a level of research in the country. Not that there is no cancer research happening in the country.
I'm not saying that. I'm saying molecular cancer research. There's very little, if any, happening in the country.
So the research that's happening in the country at Kemri, Kenyatta University Teaching Research Referral Hospital also is doing a lot of research on cancer and working with various satellite hospitals and facilities. What do we lack when they don't go molecular?
So for instance, you will go to Bomet County and then you say, we found 1,000 people with esophageal cancer. 10 of them were stage 4, 100 of them were stage 1. This number were women, this number were men. And then we looked at their lifestyle. Some of them were drinking hot tea. Some of them were probably drinking mursik and so on. And that's okay. That kind of information is okay, because you also need to have or to understand the patient lifestyle so that you can also understand the disease better. But it's not enough, because how are you going to help them once you know that you have this number of stage 4, this number of stage 3? Even if you're not going to help these people, there are patients in the pipeline coming, because remember, our quality of life is improving, so lifestyle factors are also coming in. So there are more patients coming in the pipeline. And we have some right now who we are telling, we can't help you. We can't help you because there is not enough molecular work happening. So the other thing that I can mention, in our lab actually, the other thing that we do is we deal directly with what we call organoids. So organoids are cells, fresh cells from a patient who has just undergone surgery. We pick them and we grow them in certain conditions, and then we do different drug tests on them. And the reason we do this is because some of these patients go to the hospital, and because of their molecular profile, the doctors tell them there's no drug that can help you. So they give us those biopsies, and this work is done by a colleague of mine in the lab. I don't do that personally, but that's what she does. she tests different drugs that are already commercially available but are not approved for that indication to see if it can help that patient. Because for that patient, she doesn't care that, oh, this drug is not approved for me. So if she sees that the cells can shrink in the lab with these different treatments, she then reports back to the doctor that, look, we tried these drugs in culture in the lab and they helped, they killed the cells. So maybe you can try them on that patient.
This patient.
And I can tell you they've helped 3 patients. They have helped 3 patients. And that's a lot because you cannot quantify life.
That's true.
That's time with family, with children, with the grandchildren, with friends. Yeah.
A big shout out to Patrick Ocheng, who's watching us from the US. He says he's also working on molecular breast cancer research in the US. Does the Integrated Cancer Research Foundation of Kenya work with these other facilities? Does it work with Cambridge? Does it work with KUT or ROH?
My work is easy because I use ClickUp. Here's how I keep track of all my tasks. I start by brain dumping everything I need to get done in a list view. Next, I set a priority and a due date to keep things on track. I create custom statuses to organize my progress exactly how I want it. I like to add the action items field so AI can show me the next steps. I add my teammates as watchers so they're in the loop. ClickUp makes work easy, from personal projects to running a multi-billion-dollar company. Click the link below to create your workspace for free.
So,
are you collaborating with other researchers?
Yeah. So we are still very young. We don't even have a physical place yet. But that's the point. That's even why we are doing this symposium in collaboration with Kenyatta University. Because like I said at the beginning, this is not a one-man work. It's going to take a collaborative effort of research institutions, private, public. It's going to take academic institutions. It's going to take doctors in private hospitals, public hospitals, retired researchers who want to give back. It's a collaborative effort for the public good of managing this burden. Because otherwise we will get to a point where we cannot treat this disease because everything is imported and it's expensive. And we saw it during the COVID-19 pandemic. And I remember having a discussion with a friend of mine, and I was like, Kenya has some of the best virologists in Africa. All this, and I'll probably sound political now, all this money that we spend on ghost dams and, things that don't work. If you gave this money to some of these researchers and tell them develop a vaccine, they will. Because we also have a vaccine manufacturing unit at Kavi. So we could do all those things locally here. But instead we chose to wait and import. So I just think that our priorities sometimes are not right. And that's why we keep paying these steep prices for some of these things, which we can actually develop ourselves. Yeah.
Who needs to get this message, Victor?
This message, I think, needs to go to the Ministry of Health. It needs to go to the maybe the Department of Science, Technology and Research, and also to the President. I think since cancer has become such a big burden, one thing that can really help is creating a cancer research fund. We need it to be a standalone fund where probably can get money from the consolidated fund every year. Yeah, because I tell you, if you can get money into research, you will see all those talented Kenyans who are working for different organizations, different universities out there to come back here and do research that can actually help our people, our communities. Yeah. So creation of that fund, I think, would be the first step towards saying that every year, come what may, we know that 1 billion or 2 billion shillings is going to the Cancer Research Fund, and this is what it's funding. Yeah. Then it becomes very easy to say, I want to get this reagent, I want to get this consumable. Then you don't have to, you have researchers in this country who are using their own salaries to buy consumables. I mean, you can't do research like that. You can't be competitive like that. Yeah. If we are living in a globalized world and we are always complaining that we are importing everything, this is an industry that, if well funded, in 10, 15 years, could have massive ramifications for our economy. It could produce up to probably even 10% of our GDP if we actually and are deliberately investing in it. And that's a surety that I think I have because I've seen it happen in other countries. Yeah.
So, I mean, we talk about the clamor for research by countries to be made priority and looking at certain percentage of budgets to go towards this, and it's almost becomes cliche in nature when we talk about the Abuja Declaration and how everybody promised to do whatever. It hasn't really happened. And so we're going back to that chicken egg situation. Now, what is it going to take? I mean, looking at the numbers of the burden across the continent, but what is it going to take? Because, like you said, cancer is complex. There are very many people who are working on it, looking at research under the microscope, trying to find out what's going on. It's complex in nature, so obviously more hands on deck is better. But what is it going to take for these spaces, and these spaces being countries, Kenya, South Africa, Nigeria, wherever, to say, you know what, we need to be serious about things because our populations are dying a very cruel death at the hands of cancer. What would it take? And not even as gory as death, but what awakening needs to click for this to happen? Because it is clear that you can find interventions for treatment if you do the research. It's like 1 is equal, 1 + 1 is 2. You can find them if you do the research.
So I think it has to be a deliberate prioritization of this. Just like when HIV hit home, we said we are going to put money, and the likes of NASCOP and the National AIDS Control Council, I think, came in, and a lot of money
yes,
and a lot of money went into KEMRI to try and try to understand the disease, and also a lot of donor funding came in. But cancer is a very silent disease. You don't really see a lot of it, but it's there. You go into hospitals, you see gory faces along the walls. Most of those are cancer patients. So I think I don't want us to form a commission to investigate this, because to me that's a waste of time. If you want to fund cancer research, just fund it. Just say this is a burden, and we are always copying best practices. This time around we are in Singapore and South Korea. We are copying them. You're saying they are doing this better. So we should also copy that. We are doing roads or affordable housing or dams because other countries are doing it the same. So these countries are also funding research. So just fund research. Just say, every year I'm going to put 30 billion Kenya shillings for research. 5 goes to TB and HIV, another 5 goes to malaria, another 5 goes to cardiovascular diseases, diabetes, and those two are 2 other silent diseases that are killing Kenyans. But because there is no underlying molecular research to support this, we are simply trying to treat them without necessarily, because what happens if, say for example, you go to hospital, you're sick, and the doctor tells you, we've tried all kinds of medicine, there's nothing else to do.
We can't do anything else for you,
Of course, the patient can accept it, but how do you feel as a doctor if next time a similar patient comes in and you tell them, we can't help you, and then. So that's where we come in. Such patients, we have to get their samples, go back to the lab and understand, why was this patient non-responsive to all these drugs? So you try to find a different profile. So next time you have a patient with the same profile coming in, you've already identified what was the problems. You go straight to that. You don't start from zero again. Let's start with drug A, B, C, D, and then, we can't help you. But, no, he has this profile, so we should start with this. Maybe that will help them. That's why this work is important.
Right.
Yeah.
There are many actors, of course, in this. There's the science part of it, and then there's policy, there is government, there is, those who are independent, and then there are those who are looking for the answers in terms of those then who are sick. Is there a way that it can then be beyond? Is a constant call. Look, we give an example of HIV. Everybody got into the conversation. Survivors, medical practitioners, non-governmental organizations, nations, everybody got involved in the conversation. Is it not at this point with cancer, with the interventions that are being sought, that everybody then get involved in the conversation? It can't just be the researchers with the begging bowl to government and say, please fund this thing so that we can find an answer. Must it not be collective?
It actually should be collective, because if you look at countries abroad, of course, Denmark, UK, Germany, governments put some money in research, but also people. Like you guys were announcing or advertising some weeks ago about was it the Standard Chartered Heart Run or something?
Yeah, the Nairobi Marathon. Yeah.
We could have the Nairobi Marathon, but for cancer research, where people pay in, but this money, we know, it's going to a cancer center. It's going to do research A, B, C, and D. There is a company in Denmark actually called, it's a clothing company. And I don't know the background very well, but all their profits, every year, all their profits go to, it's called NEYE, NEYE, N-E-Y-E. All their profits every year go to cancer research in Denmark. Yeah? All their profits go to cancer. And once they start doing that, there are other small companies that see and they're like, I want to be involved with this. I want to be involved with this. So if the government puts money.
Invest where your money works harder than you do. Your apartment shouldn't just sit there. It should earn you money. From Kilaleshwa to Lavington, Kilimani to Westlands, our luxurious properties are generating up to 25% ROI. Enjoy high rental yields, strong capital appreciation, and secure lifetime returns, all in Nairobi's most high-end neighborhoods. Smart investors don't wait for opportunity, they grab them. Click the link in this video below to book your unit today.
Has your soul been bruised by a betrayal by somebody who was close to you? Ending a bad, broken, or abusive relationship usually is not as easy as just walking away. This is because connections develop over time between souls of two people, your soul and their soul. We call these connections soul ties. And soul ties are often the reason people can't get over the bad of their past. Bad relationship, bad friendships, bad experiences in your family or with an ex-spouse. Hi, I'm Dwayne Vanderklok, and I've helped people for over 40 years break free from these tormenting soul ties of their past. And I'm going to show you exactly how to break those unwanted soul ties. I've also put together a free resource for you to answer the questions on how to finally break free from the negative influences of your past relationships. If you think some misery, some abuse in your past might be the cause or one or more of these soul ties, I have good news for you. Soul ties can be broken, and you can stop the pain, and you can be free. We have some completely free resources for you to download. Click the button around this video where I talk you through the process of finding freedom from soul ties. Our church is providing this life-changing information free to you and thousands of others as part of our mission to help hurting people. If you'd like more free information about escaping the clutches of soul ties, please click the button or the link around this video. Past relationships don't have to influence your life any longer. You can be totally free today. Just click that link and get started. We've all had to struggle in overcoming our past relationships that were harmful to us in some way. For some as a child, they experienced horrific abuse at the hands of a parent or a relative or some trusted person. Sometimes the pain came through a sibling. Sometimes it came through a friend. Other times the damage may have come through a girlfriend, a boyfriend, a spouse. Whatever the source of the pain, there is a way to break that negative soul tie and be free to grow, to blossom, to become all that God intended you to become. You can be free. And I hope that this gives you hope. That freedom is just a free click away. When you click that button, you will go to a web page that looks just like this. You'll find some helpful information there, and you'll be able to download the free material on breaking soul ties. So click the link or button around the video right now and start the journey to a free life, free from torment, from the negativity of your past. God bless you, and thank you.
In research, it's very easy for scientists to walk into Equity Foundation Group, KCB Foundation Group, Manu Chandaria Foundation Group, and tell them, you guys do a lot of CSR. Yeah, I know you do boreholes, you do schools, you do markets, and that's okay. Yeah. But maybe it's also time that some of that money goes towards addressing a more serious problem,
Yeah.
which is cancer research. Yeah.
What drove you into cancer research?
Curiosity. And I think it's a personal story that, so my dad died when I was 6. This was 1994. And he died from bone cancer. But because back then, HIV was really rampant. Yeah. So if you died of cancer, it was like, it just passed. But my grandmother, being a conservative, she believed that somebody did something to her son, and she still believes that to date, So,
and she has identified the culprit.
She has identified the culprit, of course. And so, because I was raised by my grandma, and it's actually one of the reasons why I come back every year, because I have to see her.
Yeah.
When I got of age and I was able to understand a death certificate, I saw my dad's death certificate and it said sarcoma. So he had died of bone cancer. And the reason why my grandma thought somebody had done something to him is because his legs were turning green. And the legs were turning green because the bone was already eaten. Yeah, so there was so much inflammation, and then it was just reactive. And because they'd never seen anything like that, so they said, oh, somebody did something.
Sure.
Yeah. So then when I got to university, I studied biochemistry at Kenyatta University, and then when it came to do my postgraduate studies, a lot of Kenyans were still going into virology. In fact, I did my internship at Cambridge in a virology lab. But then I was like, there's too many of us here. Yeah. So I decided to just take another path. So I went into cancer biology. And the rest, as we say, is just history.
It's history.
You've been on it.
I've been on it. Yeah.
For now, how many years?
Since my master's studies up to date is 12 years. Yeah.
Keep at it, brother.
Yeah, absolutely.
Keep at it. Thank you very much for joining us this morning.
Thank you also for hosting me.
Victor Oginga Oria, Lead Research Fellow at Biotech Research and Innovation Center, Copenhagen, Sweden, has been our guest. Thank you very much for joining us. Salimia watu Sweden ukirudi. Keep it here for more conversations.
This is the Situation Room, the only way to start your day.
For diabetes after the age of 20, because it's not just limited to people who are overweight who develop diabetes. No. I think it would be essential for Kenyans to now start looking at it. If I get 20, I'd want to have done this done. I want to know that I don't have blood sugar issues. If I get to the ages of 45, I'd want to check my stool to see if I have blood and know if I stand a risk of developing colon cancer. If I am a lady, I'd want to be doing a mammogram and having self-breast assessment techniques be taught to me so that I can go and check myself and see if I have a lump or not. So these are things that are conversations that are there for you with your doctors, that are there for you with your nurses, that are there for you. But it is upon us, yes, to relay this information, but it is also upon you as a Kenyan individual out there to seek them. I think that's how I would put it.
All right. Well, for those who are watching us tonight, and maybe one is encouraged by this very insightful discussion, and maybe want to take that initiative step and visit a doctor in the near future or even tomorrow. So the question is, so where do that person begin?
I think the journey starts. I'll put it this way. We live in a day and age where technology is at the comforts of your fingertips. So as much as the healthcare industry is still as old-fashioned, we, the young ones, are trying to re-diversify it and redefine it. Personally, myself, my younger brother, and other gentlemen, we are looking at it from a perspective where what can we tell these Kenyans to understand about medicine and health itself? So engaging with content and individuals who have such kinds of mindsets would help them get an exposure to it. That would be one. Two is having a positive outlook to the healthcare industry and not a negative outlook to the healthcare industry is one other way. in the sense that majority of people are scared of going to the hospital because of a diagnosis. So I would rather tell you like, hey, forget the diagnosis bit. Come see me for the sake of, let's figure out why does high blood pressure come about? Can you help me understand why prostate cancer is here? And how does it look like when it gets to me? So I think we should allow Kenyans and make Kenyans understand that it is no longer in the hospital now. It is something that is accessible to you on your phone, that you can actually sit down, listen, including this platform as well. And I think it will be it's something that is catching on, but it still needs more time to get there.
All right. Well, Doc, I will give you the next 1 minute to actually for your, to make your closing remarks, even as we wind up this particular discussion.
Thank you so much. Generally, it's been a pleasure. I'd like to tell Kenyans that we could be smart about certain decisions, and that doesn't mean we've been dumb for the past few years. No, it doesn't mean that. But I think the generations that the current generation and the ones behind after me and before us, there is something we could always learn from one another. And I think being proactive about your health is one way to go about things. And this platform offers you that. Our platform, the Laughing Lab Coach, offers you that, and it is engage with us. I think it would be easier, and we could have difficult conversations, but with ease, and be able to live a healthy life rather than an unhealthy life, which would cost you bills and stuff. So
All right.
that would be my final piece. Thank you so much.
All right. Thank you so much, Dr. Muhyiddin Mohammed, expert in critical care and internal medicine. This has been a very, very important discussion in regard to matters health, and of course, that, like they say, always prevention is better than cure. And who is best to tell, or rather to advise you on the matter than the doc himself? So that has been very insightful discussion, and we hope you'll take proper measures and actually, wake up from slumber if you're still dilly-dallying and waiting for the next course of action.
In my lab, we use PCR as a main research tool to study malaria, which is one of the major tropical diseases. Each year, malaria kills about 500,000 people, and there are more than 200 cases of malaria per year. We use PCR for many things, from gene cloning, genetic engineering, disease detection, and genotyping. We work both in the lab scale and also at a population scale. We've been using standard qPCR for malaria detection for the past 8 years, and the existing qPCR assay is very sensitive, and it can detect a minute amount of parasite DNA in human blood. So we are now supplementing our malaria survey pipeline with Kaya QED digital PCR. We are using it to prepare and quantify the absolute copy number of our internal standard controls. And we are also using it to analyze difficult, highly challenging samples that are hard to detect. We have used a 26K partition to identify a few unknown samples, which could not be identified by our standard assay. To us, QIAcuity workflow has been very well simplified. It still maintains enough flexibility for us. It has allowed us to do more than we could, and we are now exploring the opportunities that come with the machine.
QIAGEN. Sample to insight.
QIAcuity DX is an all-in-one integrated IVD medical device that simplifies the workflow in a lab, reducing servicing needs, lab space required, and most importantly, the amount of operator time required to run dPCR diagnostic tests. We are introducing QIAcuity DX as the latest member of our QIAcuity digital PCR suite of instruments. Labs already familiar with their QIAcuity ecosystem can expect the same simplified nanoplate-based workflow. This provides highly precise, absolute quantitative results of target DNA without the need for standard curves, reducing variability and improving accuracy. With our focus on patient safety, we designed the QIAcuity software for diagnostic use while maintaining the ease of use and efficiency from our QIAcuity ecosystem. Its user-friendly interface ensures that every member of a lab team, from lab administrator through to newly trained technician, can operate the system with confidence. This provides a full and clear audit trail compliant with the needs of modern labs. Its simple workflow and small footprint makes QIAcuity DX ideal to use in healthcare facilities of any size. This helps to decentralize testing away from diagnostic hubs and closer to patients, reducing time to result and improving lab efficiencies. We invite labs to enhance their full potential with our QIAcuity DX digital PCR system. Make reliability and precision the foundation of your diagnostic testing.
QIAGEN. Sample to insight.
Using qPCR, if one wants to detect very low frequency events such as rare mutation events or small increases in copy numbers, one has to use a lot of replicates and a lot of reference samples in their experiment to make sure that they will cover the increase in the mutation rate or the increase in the copy number.
Actually, a nice alternative to qPCR, especially when you're looking for a higher precision, is digital PCR. So the nice thing about digital PCR is the partitioning, because you partition your PCR sample, or basically your PCR reaction, into thousands of little individual reactions. And one way to do it is with droplets, so ddPCR, but there are also limitations with droplets. So one would be, for example, you never really know if you've got always the same droplet size, or the same number of droplets for each and every run. And you have to read out each individual droplet after another, so it takes time. And it would be actually very nice to combine the ease of use also with digital PCR, so the power of partitioning. This is actually quite nice, which now QIAGEN has got established in our nanoplates.
In digital PCR, we use plates that are very similar to the qPCR, so we are very familiar with the system, and depending on the sensitivity of the experiment or the sensitivity of the reactions that we set up, we can use either 96 well plates or 24 well plates. And the number of partitions in 24 well plates are increased in comparison to 96 well plates, which allows also increased sensitivity of the detection. The biggest advantage of having a closed system in the plates is having a carefree experimental setup. User can just set up, seal the plate, and just walk away. And that makes the life of a researcher a lot easier.
QIAGEN. Sample to insight.
In drug discovery and development, researchers require precise instrumentation for genetic analysis. Digital PCR is a powerful new tool for quantifying target DNA with extreme sensitivity. Early in the drug discovery process, the technology enables absolute quantification of RNA transcripts, resulting in extremely accurate measurements of gene expression changes. In later stages, while clinically evaluating drug efficacy, digital PCR can be used to identify genomic sequences in liquid biopsies. Like real-time PCR, digital PCR uses a simple sample preparation that utilizes TaqMan primers and probes and an optimized supermix. Real-time PCR provides relative quantification, and in contrast, digital PCR provides absolute quantification of a target DNA sequence in the sample. Let's see how droplet digital PCR achieves precise DNA measurements. The key is sample partitioning. With droplet digital PCR, reaction mixes are partitioned into approximately 20,000 evenly sized droplets, each 1 nanoliter in volume. PCR is performed on each individual droplet. If a droplet contains the target sequence, it will be amplified and a TaqMan reporter dye will emit a fluorescent signal. If the target sequence is not present in a droplet, no PCR will take place and only weak residual fluorescence is emitted. By scoring each individual droplet for a fluorescence signal, Droplet Digital PCR achieves absolute quantification with a high level of precision and single molecule sensitivity. Now let's look at how the Bio-Rad QX200 Droplet Digital PCR system performs digital PCR with unrivaled precision and sensitivity. The QX200 system uses a simple workflow that requires minimum hands-on time and procedures that are easy to perform. First, 20 microliters each of 8 prepared samples are transferred to the droplet generation cartridge. Droplet generation oil is then loaded into corresponding channels in the cartridge. There are 8 oil channels, 1 for each of the samples. Once the cartridge is loaded with prepared samples and oil, it is placed in the QX200 droplet generator. Using microfluidic technology, the droplet generator combines the samples and oil to create an emulsion of approximately 20,000 mono-sized droplets for each sample. Every droplet contains a nanoliter volume of the sample, including any target sequences that may be present. After the droplets are generated, the emulsified samples are transferred to a standard 96-well PCR plate using a standard 8-channel pipette. The plate is then loaded onto a thermal cycler where PCR is performed to amplify the target DNA to end point. When PCR is complete, the plate is loaded onto the QX200 droplet reader. The QX200 droplet reader is an automated liquid handling device equipped with optimized microfluidics designed for precise, reproducible detection of target DNA sequences, droplet by droplet. The droplet reader automatically sips each sample, singulates all the droplets from a sample, and then streams them in a single file past a 2-color fluorescence detector. The detector reads each droplet in turn at the rate of thousands of droplets per second and determines which droplets emit fluorescence and which do not. As each droplet is read, the data are recorded graphically by Quantisoft software. The software records the positive and negative droplets in each sample and plots the droplet by droplet fluorescence. This allows the data to be analyzed and visualized according to the specific application and research requirements. Droplet Digital PCR simplifies the process of identifying and testing a potential drug target by enabling the absolute quantification of target DNA, allowing for precise gene expression measurements and tracking of genomic sequences in liquid biopsies, along with many more applications. Examples of these applications include copy number variation, mutation detection, and gene expression. QX200 Droplet Digital PCR, the future of quantitative PCR is here, and it's digital. Be part of it. For more information about the QX200 Droplet Digital PCR system, visit our website or contact us directly by phone or email.
GoDaddy 能够为任何网站提供优质的虚拟主机方案，每个方案都享有99.98%的正常运作时间保证，以及免费网域。立即使用 GoDaddy 释放您的线上潜力。
Montana. Skia, ni juicy. Flavors zote tamu tena fruity. Are you bored? Kuna vitu. Ayaya, kituka na shika. Yummy na flow kama maji. Tena fruity. Are you bored? Kuna vitu moja juu ni tamu kama sali. Ni juicy. Flavors zote tamu tena fruity. Are you bored? Kuna vitu zinakuudhi. Sijali my bro, hebu kama taka juicy juu ni juicy. Flavors zote tamu tena fruity. Are you bored? Kuna vitu zinakuudhi. Sijali my bro, hebu kama taka juicy juu ni
This is a simulation of Pong, the iconic 1970s arcade game where you use this paddle to stop this ball from getting past you. It's a pretty simple game for us humans to learn, and as of quite recently with advancements in AI, computers can learn it too. But today, Pong has a new kind of player, not a computer, nor a human. A cluster of living human brain cells on top of a silicon chip can play Pong. Yep. Researchers in a lab taught a tiny clump of neurons to, in a sense, play this video game. But it's more than just a game. Some believe merging biology with computing could upend our approach to artificial intelligence. AI is a massive, often volatile, global market, with people looking all over for a competitive edge. In 2025, private sector companies teamed up to invest more than $500 billion in AI infrastructure alone. But what if the building blocks of that infrastructure include living human brain cells, with the promises and challenges of our own biology? Sounds like sci-fi, right? Well, we're kind of on our way.
Science fiction talked about this.
I love thinking about the Hollywood stuff, like, are we really computers? Are computers really human?
My life has been focused on how can you elicit intelligence from brain cells in a dish. I've got a pretty broad background. I did some work starting with cognitive psychology, neuropsychology, and then eventually moving into neuroscience.
Brett Kagan is the Chief Scientific Officer at Cortical Labs in Melbourne, Australia. They made a name for themselves when they got their neurons to play Pong in 2022. They called it Dish Brain.
Yeah, let's just set up and see how it goes. Maybe we'll all be in for a surprise.
Quick timeout. Before we go any further, it might be worth understanding why companies like Cortical Labs are blending living neurons with synthetic systems. Compared to traditional machine learning, brains need far less training data to understand real-life environments and new situations.
So what you're seeing here is we're investigating, can neurons actually distinguish between different handwritten digits? And we want to see, can the neurons behave in a way that says they recognize that all of the sixes look like sixes, all of the fours look like fours, and so on. Anything with biology can learn to navigate its environment incredibly quickly, incredibly efficiently. And we've had to learn to do that through evolution, otherwise we died.
The promise of far less data and energy consumption is the holy grail for AI advancement. Here's why. Supercomputers like this one can be 1,000,000 times more powerful than the fastest laptop. But both supercomputers and AI run on the same basic technology, silicon chips.
There's never been a focus like there is currently on the chip industry. People have realized that chips are the heart of everything, that this fundamental change to the economy that's being promised in the form of AI depends upon semiconductors, depends upon their rapid development, and depends upon an ever-increasing supply of them.
For over 50 years, we have been creating better chips by packing more and more transistors inside one integrated circuit. The transistors are on-off switches, the physical manifestation of ones and zeros. And we've gotten faster and faster by going smaller and smaller. Over the last 6 decades, we've been trying to double the amount of transistors on an integrated circuit every 2 years. This is the heralded Moore's Law, observed by this guy back in 1975. Today, a phone's processing chip contains billions of transistors, and those transistors are so small, they're just a few nanometers apart in places. But, as our good old Intel co-founder, Gordon Moore, observed, this steady march of progress also has an endpoint.
You're creating a chip, a three-dimensional circuit, by depositing layers of material on a disk of silicon. Some of those layers now are 1 atom thick. Guess what? When you get to 1 atom, you can't go any thinner.
So, we have a problem, and folks all over the world are looking for solutions to our processing limits. After all, our demand for more computing likely isn't slowing down.
It's not like suddenly companies and governments and organizations are going to say, you know what, we don't need more data. Everybody wants to collect more and more data, right? People liken it to the, modern gold rush.
I wonder whether DeepSeek has kind of changed. I mean, it feels like it's upended the race this week.
DeepSeek is such a fundamental change to the economics of what's going on.
DeepSeek's January 2025 effect on markets was a strong reminder of these economic incentives. Companies are racing to build more efficient AI models all around the world, at times also fueling existing political tensions.
The president said that he believes that this is a wake-up call to the American AI industry.
One long-standing breakthrough in AI comes from biology and our ability to replicate it back to neurons.
The state of data and computing right now is pretty exciting, right? There's a lot going on. A big part of that is trying to learn what we can from how neurons in the real brains and biological brains connect to each other and how they communicate. And then seeing if we can take what we've learned about the biology and then hardwire that into artificial systems, into computational systems. And that's where sort of these ideas of like artificial neural networks and deep learning came from. And the current status of these artificial neural networks and deep learning is pretty fantastic.
But building these AI models and allowing masses of people to use them is costing a lot of energy.
Already there are parts of the world where there literally isn't enough power available via the grid to support these giant data centers.
How do I stay cool in Dubai? Well, you've got to go to the right places.
Try this 8-minute AI study habit after work. Get ahead of your colleagues and boss.
So this is how I became the most dangerous person in the room. One habit changed everything. I replaced social media with micro-learning. Now, instead of wasting time on social media, I spend 15 minutes a day actually learning how to use AI for writing, planning, brainstorming, the real work. That's it, just one skill a day. This is the 28-day AI challenge built for beginners over 40. Starts tomorrow. Tap the screen to join us and try the one habit that really makes you unstoppable.
By 2034, data centers around the world are expected to consume roughly 1,580 terawatt hours yearly. That is about as much as is used by all of India.
To use the words of Jensen Huang, the CEO of NVIDIA, there's $1 trillion of infrastructure out there that needs to be modernized. The old way of doing things just simply doesn't stack up to the needs of modern computing.
So neurons might help solve some problems, especially around energy. Our brains are much better and more efficient in similar tasks to AI. For example, a supercomputer must consume up to 40 megawatts of power to function. Our brains run on just 20 watts. That's the difference between a couple of LED light bulbs and thousands of homes. Our brains are also powerful, with about 86 billion neurons that form over 100 trillion connections to each other. And with cells, the distinction between hardware and software isn't quite as well distinct. They're dynamic and intertwined. The cell's actual structure can change and mutate too.
Because of the way that computer chips are organized, they have limited logic functions. They tend to want to do things one thing after another. That's what they're good at. That's what they were designed to do. Human brain doesn't work that way. The human brain is kind of a lattice structure of interconnections where information flows in sort of different ways and different points. So the limitations of bio is that we're just at the very beginning of it.
DishBrain was our first prototype. We were essentially trying to ask the question, can you interact with a bunch of brain cells in a dish and get them to do anything useful at all?
Brett and his team started by growing a layer of 800,000 neurons on top of a silicon chip. That's about the size of a small bumblebee's brain. And since neurons in our brain naturally communicate using electrical impulses, the researchers could both send and receive impulses between the neurons and a computer hooked up to a silicon chip. To translate the Pong game into something this clump of neurons could sense and control, the chip is divided into 3 sections. There's one larger sensory section, which sends electrical impulses to the neurons to represent aspects of the game, like where the ball is. There's also 2 motor sections. If neurons send impulses in this one, the paddle moves up. If neurons send impulses in the other, the paddle moves down. The chip acts as a communicator between the neurons and the game, but it still doesn't mean that these neurons would want to play the game.
Why would a bunch of cells in a dish actually change their activity in any particular way? There's no Pong playing gene that exists in brain cells to make them want to play the game Pong.
So the researchers tried to give the neurons
From pilot to population scale sequencing, the NovaSeq X series scales with you. Powered by XLEAP SBS chemistry, our fastest, highest quality, and most robust sequencing by synthesis chemistry to date. XLEAP SBS nucleotides use a novel improved block and linker, and a new polymerase engineered to incorporate nucleotides faster and with higher fidelity than ever before, delivering up to 2 times faster incorporation rates relative to standard SBS. XLEAP SBS chemistry also enables up to 3 times faster block cleavage, further improving cycle time. XLEAP nucleotides are more resistant to heat stress, 50 times more stable in solution, and 500 times more stable when lyophilized. The improved stability translates to fewer unblocked nucleotides after heat stress, enabling improved base calling accuracy and ambient temperature shipment of reagents. The NovaSeq X series allows your lab to shrink total cost of ownership with breakthrough innovations in chemistry, informatics, operational simplicity, and streamlined workflows. The workflow has been optimized to minimize time and labor. The NovaSeq X series incorporates thoughtful ergonomic design and usability innovations such as extra-large 4K resolution touchscreen to clearly view run progress and performance metrics, lightweight reagents, buffer cartridges, and waste containers that are easy to handle, user-specific safe settings for the adjustable screen and soft-close doors and drawers, individually addressable flow cell lanes with automatic library loading, automated onboard cluster generation and post-run wash, and touchless secondary analysis for key applications and more. Onboard Dragon speeds up computing and features built-in lossless data compression, with easier and faster data transfer and management with automated compression of FASTQ files. A smaller data footprint also reduces storage and energy consumption costs. Plan your integrated Dragon analysis in the cloud or locally via Illumina Run Manager, or utilize the 4K touchscreen. Select multiple simultaneous analyses per flow cell, including BCL to FASTQ conversion and application-specific analyses. Reports will be accessible on instrument for onboard analysis. The NovaSeq X and NovaSeq X Plus systems were purposefully designed to reduce environmental impact. The improved robustness and stability of reagents, including several in lyophilized format, allows for shipping at ambient temperature, resulting in less waste and elimination of dry ice. Remarkable benefits are delivered through the cost and operational efficiencies enabled by a 90% reduction in packaging waste and weight, 50% reduction in cartridge volume, and the use of biopolymers and recyclable plastics. Handling is much easier with lightweight reagents, buffer cartridges, and waste containers. Load-and-go reagent cartridges feature thaw windows to visually verify that reagents have thawed completely. The system will lead you through the process of run preparation and reagent loading. The light bar and drawers will guide you through the steps. The instrument will check that all RFID-encoded reagents have been loaded properly. Sequencing will begin after pre-run checks, minimizing the chance of user error and ensuring compatibility of reagents. Monitor the progress of your sequencing run and view detailed performance metrics from the instrument or via the cloud. With substantial application breadth and revolutionary performance, the NovaSeq X series redefines the limits of high-throughput sequencing to propel genomics research forward. Beyond the significant reduction in cost per gigabase, the NovaSeq X series incorporates cost efficiency throughout the workflow, including operational simplicity, integrated data analysis, sustainability advancements, and world-class support. You are ready to change the world. With the NovaSeq X series, you can.
Before 1986, the isolation of genetic information was a very time-consuming, complicated, and dangerous process. The DNA within a biological sample had to be separated from all other molecules in various steps, often with uncertain results. With the introduction of the kit concept, QIAGEN furthered the revolution of molecular biology. The extraction of small, circular DNA molecules found in bacteria cells now takes only 2 hours. The introduction of the first generation of kits, which contained all components needed for the isolation of genetic material, just like the current products, is considered a cornerstone of QIAGEN's success. By comparing the different methods, one can see just how revolutionary QIAGEN's development was. The traditional method consisted of many single steps. The stabilization, purification, and processing of a sample would therefore take up to 3 days and was not highly reproducible. QIAGEN's kits, however, made the same process shorter, safer, and more efficient, also providing significantly better results. The kit concept was the first of many other innovations to follow that standardized laboratory work and paved the way for further dissemination of molecular biology. Today, QIAGEN also offers automation of entire workflows, from sample to result, such as the QIAsymphony RGQ platform. Today, the company is a technology and market leader in all areas in which sample and assay technologies are used. From molecular diagnostics to academic research and the pharmaceutical industry to applied testing, which includes veterinary medicine, food safety testing, and forensics. QIAGEN, making improvements in life possible.
Hi, my name is Florentin Sandwald and I am an application specialist here at QIAGEN in Hilden. And I'm here today to show you how it is to have an Easy2Connect in your lab. The Easy2Connect is a nucleic acid purification instrument. But it does not just automate some parts of your workflow, it automates everything from lysis to elution. So let's go purify some nucleic acids. For this demo, I will use formalin-fixed paraffin-embedded tissue sample, or short, FFPE. If you are familiar with this kind of sample, you know how hard it can be to get nucleic acids from these. There are usually many steps necessary, so automation is very challenging. For our FFPE samples, I will use the EZ1 and 2 DNA FFPE kit. It's named this way because you can not only use it on our Easy2Connect, but also on the EZ1 Advanced XL. The EZ1 and 2 DNA FFPE kit comes with everything you need to treat your sample. Buffers, solution, tip holders, filter tips, tubes, and the already pre-filled ready-to-use cartridges. So the time you need to prepare your sample is drastically cut down. So my first step is to add paraffin removal solution to the tube that has my sample. Now I put the tube into the heater to heat it up to 80 degrees for 2 minutes. Here's a sample that I've already heated. Now I can open the tube and put it into our instrument. The Easy2Connect can treat up to 24 samples at the same time. On the display I can select my sample type and the kit I want to use. Now every protocol that is available with this kit is shown. So I pick my protocol and in the next step I can define my elution volume. So this is fine. In this screen we select our sample position. We positioned our sample in row 12. So I can select a single row, I can select multiple rows, and I can select all rows at once. But let's stick with row 12. In the next screen we see our sample IDs. We can rename them, or the Easy2Connect will also auto-generate sample IDs. You can add additional nodes to the samples if you have anything to mention. Now we are going over to load the racks. First, we are going to load the cartridge rack. For this, we take one of our cartridges, invert it a couple of times so the magnetic particles are mixed, and then we can put it into our rack in the position we defined. Now we put the cartridge rack back into the device. The last step shows us how to load our tip rack. So take a tip holder and the tip, and we put it in row C. So I take an elution tube, remove the cap, and I put it in row D. Our sample is already in row A. If you are unsure, you can just click on the positions and the instrument will highlight which labware goes in which row. So now we are done. We can close the hood and click on Next. Now we get a short summary of our run setup. If everything is fine, we can just click Start. Now here's where the magic happens. Unlike other benchtop instruments of this size, the Easy2Connect is equipped with everything that you need to generate a maximum degree of automation. It pierces the cartridges itself inside of the instrument and uses pipetting tips to transfer liquids and magnetic beads inside of the liquids. A strong magnet bar is used to hold the beads inside of the tip. This is one of the features that makes this instrument so special. While conventional approaches only allow to transfer beads from well to well, the Easy2Connect can also transfer liquids. This allows the automation of work steps like adding enzymes or solutions. The Easy2Connect can heat up samples, so protocol steps with heat incubation can be automated, or work steps can be optimized by applying a certain temperature. Now, let's look at some other kits you can use with the Easy2Connect. Here is the Easy 1 and 2 CCF DNA kit. You can use this kit to purify cell-free DNA from up to 8 ml of plasma. Then there's the Easy 1 and 2 DNA tissue kit. This kit isolates DNA from virtually every common type of tissue. To isolate gDNA from 200 or 350 microliters of blood, the Easy 1 and 2 DNA blood kit is the optimal solution. The Easy 1 Virus Mini Kit version 2 isolates viral DNA and RNA regardless of sample type, whether serum, plasma, cerebrospinal fluid, urine, respiratory samples, or other cell-free body fluids. If you want to isolate RNA, the Easy 1 and 2 RNA Tissue Mini Kit is the kit you need. If your sample type is not addressed by these kits, remember that QIAGEN has also other kits and is always inventing new solutions for you. The actual progress of your protocol is shown on the right side on the display, so you are informed about the ongoing all the time. You could also leave the lab and monitor your run progress from outside. You can do this by installing the MyQIAsphere app on your preferred mobile device, or by using the MyQIAGEN internet widget on your laptops or desktop PCs, just by using your MyQIAGEN account. Once the run is complete, just open the hood, grab your tip rack at both sides, and put it gently outside of the machine. Then you do the same for the cartridge rack. Close the hood and click on Finish. And now, here's your elution with high quality nucleic acids isolated from your sample with just using very few manual steps. If you want to try out the instrument inside of your own lab, the QIAGEN sales team is more than happy to help you. Call us now and experience the Easy2 Connect in your own lab. And I'm sure you will find it easy too.
QIAGEN. Sample to insight.
For years, Pathologists Lancet Kenya has been at the forefront of medical diagnostic in Kenya, providing accurate and reliable results. Now, we are embarking on an exciting new chapter. We are now continuing our journey as Saba Lancet Kenya, your trusted partner for medical diagnostic, and will be strengthening our presence and expertise in Kenya while remaining a strategic hub for our subsidiaries in the East Africa region. Operating in 15 counties, all our laboratories are led by a team of board-certified pathologists. As Saba Lancet Kenya, we proudly hold ISO 15189 accreditation. We utilize cutting-edge diagnostic tools and streamlined processes to deliver fast and accurate results. As part of Saba Lancet Africa, you will have access to a comprehensive range of services, including over 4,000 tests, from routine checkups to specialized diagnosis, and giving you access to a wealth of skills, expertise, and resources, making us a global healthcare provider and allowing us to remain at the forefront of medical advancements. At Saba Lancet Kenya, we are committed to providing you with world-class medical diagnostic closer to home. Welcome to a new era of healthcare excellence.
And Lucas Nyabero. But if you look at the second sponsorship session, it's also all on cancer genomics. So we'll just combine the four together. So we'll have four presentations. Take note of your questions, and then at the end of the session, they'll be standing in front here, and they will respond to your questions, okay? And then afterwards, we'll have the last session, which is innovation and training, with Francis, Robert, and Jeremy. And then we will have our tea break and networking. And for networking, again, we just go to the booths, and then we'll call it a day, and then we'll see each other tomorrow. So I'll just ask if George is ready. He can come and we can start.
Good afternoon. As you've been told, my name is George Ngondi Michuki. I'm the founder and CEO of the Africa Genomics Center and Consultancy and NextGen Molecular Lab. But today I'm here on behalf of NextGen Molecular Lab for the purpose of what we'll be discussing. So I'm just waiting for it to go up. Okay, thank you. So I'll be sharing about the topic from blood to treatment, where I'll be discussing a very specific project that will try to explain that. And just to do a disclaimer, when it comes to a lot of hard pharmacogenomic questions, please reserve them for the next presenter. So next. So that's just the outline of what I'll be discussing. Maybe next slide, please. Thank you. So I'll introduce what precision medicine is for the sake of myself and next presenter so that he doesn't have to repeat that. He can just handle the questions. And precision medicine, I'm sure most of you already know that it refers to the use of individual genetics makeup to actually understand how you respond to different factors like disease, and it encompasses everything, including your environment, your DNA, and all that. And so when we are talking of genomics, we are talking about studying the DNA so that we can get all those messages that are encompassed to give that information. So next slide, please. So for pharmacogenomics, now that goes into pharmacy of genomics. So we are basically talking about how does your DNA speak to how you respond to drugs that you take. So it has nothing to do with drug dealing. It's more about the clinical drugs, but it could also infer how you respond to the other drugs as well. So thank you. Let's go to the next slide. Just to highlight what is pharmacogenomics and precision medicine. When we look at ourselves in this room, we are all very diverse genetically. And so that would infer like what we have. We have some of us who are blue, some who are red, some who are green, and so on. Now you can imagine having one drug that you use to treat a condition that affects all these people, and we're using one drug. Do you expect that we should all respond the same? The answer is definitely no. So when we are talking about pharmacogenomics, we are saying which drug is specific for the red person, specific for the green person. And so this is where we have to understand your DNA for us to actually be able to give you the right treatment that is very specific for you. Next. Next, I've already talked about that. Yeah. So I'm going to give a story, or rather to talk about a study that I would say is more actually not a study. It's an analysis of diagnostic results for a cohort of patients that had prostate cancer. And it was a different study to develop diagnostic tools for prostate, but in the process, the patients who provided the sample, we provided them a free testing for pharmacogenomics. And this, what we'll share, is about what we actually found from their diagnostic reports. Next slide, please. Okay. Just to highlight, the reason I'm sharing this is because I'm also trying to think in terms of a researcher as well as what a clinician would be thinking about, and just also to share what does it involve. So for you to do pharmacogenomics, what you need is the DNA, and there are two options. You could either be doing germline or somatic. Now, when you use the blood of a patient, it means you're actually looking at the germline. And should you want to look at the somatic, which is now specific to the specific cancer, that's when you get your DNA from the tumor. So most of the time, germline, we talk about hereditary predisposition and those kind of things. And in this case, for the patients that we had, we actually used blood, so it means it was more of their germline DNA. And critical is for you to get good quality DNA, you need let's say the blood sample. How do you process the blood sample? How do you collect it? In most cases for DNA, we talk about using EDTA blood tubes, or you could use, currently there are several manufacturers who are also now making room temperature tubes that are specialized to preserve DNA. So that's an option. In this particular one, we used EDTA DNA tubes, which were shipped in cold chain, and we did DNA extraction usually it was within 2 or 3 days of sample collection, because we were doing the study with a cancer center in Meru. So once we get the sample, we'll do DNA extraction. We processed the DNA to create next-gen sequencing libraries. And for these, we were using the Illumina platform. And once we got that, the target genes that we looked for were the listed genes, the 22 genes that are listed. Why we picked these are genes that are already known to be relevant in the HRD pathway. And the reason we picked the HRD pathway because it explains how your DNA repair mechanism happens. So these genes would help us tell, do you have faults in your DNA repair? And this is what the earlier presenter talked about, how some cancers means crosslinks and all that, you have failure, so do you have the mechanism to fix that? So when you are taking chemo drugs, they will definitely interfere in some of these processes. And so we analyzed these genes, and that is where we found very interesting results from our population, considering this was like a first time this was happening. So next slide, please. Okay, I wanted that was not okay. So once we analyze what we do, and this is where it's important for us to share. For a researcher, you know very well from sequencing, you get FASTQ files. Once you get FASTQ files, you'll probably get the sequences, you analyze the sequences, and you get the Please go back to the last slide, please. Not the next one. Okay. You can still leave it at that, then I'll talk about the report. I just jumped into the report. So before we get the report that you had just seen, is that we take the whole sample through the actual process that would happen in a research setting, where we'll assemble the reads after checking the quality. And when it comes to diagnostics, we need very high quality reads. So for this particular case, we were not considering any reads that had below a Phred score of 30. So we wanted very high call basis, and this is what we took to the mapping, and this is mapping to the reference genome, the human reference genome, and so we are able to call the variants. But now the question is, once you have the variants, what do they mean? This is where most of the time we keep saying that we have limited data to be able to make a lot of inferences for quite a number of diseases. But then there are still a starting point. As much as there's not much data on the African continent, there are things that are already clear and known. For instance, if a drug is known to target a mutation X, and you are in Africa and you already have that mutation X, does it mean that you will be different from the existing data? And so that is why we felt that we cannot say we will not start and we will not do it because we don't have the data. You start with what exists and then work to build more. So what we did was we went further to using existing databases to infer what those mutations identified in those genes meant. And what we normally generate now as Next-Gen Molecular Lab is a clinical friendly report that the clinician does not need to understand how you process FASTQ files, how you do the VCF calls, and how you interpret them. We give them the interpretation. And from this interpretation, that's what we generate. Next slide. This is where now we come up with a sample report that is friendly to clinicians, and it goes specifically just to report this patient has these mutations, and these mutations from existing data shows that this confers resistance to A, B, C, D, and sensitivity to A, B, C, D. And so now what I want to share is what we found from the small patient group that we did the HRD test. Next slide, please. So these were the key highlights, which are quite interesting because we did the test on 37 prostate cancer patients. And one of the things that was of critical interest was that 30 of them had an MR11 gene mutation that conferred them resistant to apalutamide. Today in Kenya, especially if you go into public hospitals, if you're diagnosed with prostate cancer, the most likely drug that will be prescribed to you is apalutamide. And what does that mean when you have apalutamide resistance being observed in close to the 80% of the small cohort that we were working with? And this was same community because it was a hospital in a rural setting. So the tribal distribution is actually the same tribe, same community, because people come from within the surrounding of the hospital. The other thing that we observed was there was also about 20 of them resistant to rucaparib. And just to preempt, we had about 30% again resistant to radiotherapy. And so why is this something worrying and important? This brings to you the importance of actually doing pharmacogenomics and why we need to do this. You can imagine what you are doing to the patient who has resistance to apalutamide, and you are giving them treatment to wait for 2-3 weeks or a month to see how they're going to respond. So it means by the time you're realizing that this patient is going through hell or you're not helping them, you're actually adding more conditions and other side effects that are not necessary and results to more problems. And so I know my colleague next will speak more about this. The other thing that we noticed is that from the same data, so there were clinically significant mutations as well as pathogenic mutations. There are a number of the patients that we found to have the pathogenic mutation, and one of the major one was the MR11 deletion of C is being deleted from position 315, and we had about 7 of them. And this is the region linked to increased radiation sensitivity. Now, this is a plus and a negative. How? And this is where now the clinician needs to make decisions. Now, if this patient, let's say for instance, they have this mutation on the tumor, and this is now somatic, but they lack that mutation on the germline. What does that mean? It means the tumor actually has a mutation that makes it more sensitive to radiation, and it means you can actually use radiotherapy to treat that tumor, and it will be very effective. But now the question is, if this is on the germline, it means exposing that individual to radiation, you're actually causing more harm to the individual. So these are some of the things that it doesn't mean because you get these results, you just use them as they are. That's where now the clinician needs to make those kind of decision makings. Then the other genes we found were like the RAD51D, those kind of mutations and all that, all of them showing different kind of effect on the drug responses. Next slide, please. Then in the same thing, and then this is where it came to our realization that we need to stop targeted screening vis-a-vis panels. Why do I say this? So you'll find someone who do not have those mutations like the MR11 and all that, but they have other benign variants that there is data showing that those benign variants actually do contribute to how you respond to some drugs. So you can imagine if you decided to do a targeted test of MR11 gene to look for that specific mutation, the same way sometimes we do for BRCA, and you're looking for just BRCA2 mutation, and you find the mutation is missing, so it means maybe the patient can respond to this drug. What happens to those other genes? Because this is an organism, it's not a cell that has only that particular section. So it means as much as they have something showing it's okay, they could have something that you're not even thinking about that could have a different effect on the same particular drug. And so for this, you found that people didn't have the pathogenic mutation nor the clinical significant mutation, but from their benign mutation, they had these particular mutations, which there is data to show they actually confer some of these resistances. And one thing I'd like to mention is that there is currently a study that is actually going on. It's a clinical trial. None of the sites in Africa. It's happening in Europe. And they're actually doing a trial to look at combining apalutamide and radiotherapy. And it seems to be working very well in the population that they're testing. And my worry is this: they will have very good publications showing that that combination is very effective and works very well. From just this small sample set, what does that tell us? That drug will be sold here because it's already here, apalutamide, and now there will probably be a recommendation for it to be used in combination with radiotherapy, which we've seen quite a good number also resistant. And so is that drug really going to work for our population? And so this is where I throw back the challenge to scientists, researchers here. So what do we do? This is why we need more people doing genetic studies and genomics to actually have more studies and bring those clinical trials in Africa. Let us get data that also includes our African population. Next slide, please. So what's the way forward? The way forward, of course, for us, we plan to do more of this, and where we'll be looking now to even look at how do you compare both germline and somatic, because you could have beneficial use where the mutations in the tumor could actually allow you to use a drug that the germline side is not applicable. But then that will have a better benefit in terms of the response to the tumor. At the same time, there's really key importance or need to now integrate pharmacogenomic testing into our routine clinical tests, because it means you can imagine you've taken a patient through 1 year treatment with apalutamide, and it causes development of other conditions and all that, and you're assuming this is a known drug that works for prostate cancer, and you start treating those other things with other drugs, and yet the problem is actually what you are giving the patient. So what if you could just test before administering any drug and give the right drug? It may look expensive, but I call it cheaper at long run. Because if you do these one tests and gives you the right treatment, you start with the right treatment from the word go. You don't have to throw a dice to try this. Then maybe the next trial will be a wrong drug and a wrong drug. And let's say the person is in stage 2, stage 3 of a cancer. Do you have time for try and error if you are starting at stage 3? So my take is that we really need to think of policy frameworks to integrate pharmacogenomics testing and building capacity for it. Next slide, please. Let's go to the next one, please. Yeah, so this brings the key highlight where we say cancer treatment shouldn't be a one-size-fits-all because we are all different. Imagine this was one community, same people, but we still had variants where some had this. And note, we also found variants that are not reported. Like nobody knows what those variants are, which opens up an opportunity for a lot more further studies and work. So I think I can go to the last slide. So just to highlight, so this study, we did it at the Cancer Center was Aroha Cancer Center in Meru, and we worked in partnership with all these teams. The funding was from Pfizer and Limolson and BioLinks and TAGCC. Thank you.
Thank you, George, for the talk. So just write your questions down, and then at the end of the session, you will ask questions and they will respond. So next, I'll invite Lucas to come and share his work with us. Welcome.
So, I'll start with a couple questions. My name is Dr. Lucas Nyabero, and I am the, what? You need this? I don't know, is this for moving forward? But it's not. Oh, okay, fine, I'll use this. So my name is Dr. Lucas Nyabero, and I am a clinical pharmacist, the doctor of pharmacy, and then I also did genetics from 2016. And now I'm the CEO, and I run Elara Health Innovations, which is a healthcare consulting firm. So I'll start with a couple stories. Story number one, I used to take care of patients, sickle cell patients in another jurisdiction where I used to live. And patients would come in and tell me, morphine doesn't work for me. I want meperidine. And I would say, you must be a drug seeker because you know exactly what drug gives you a fix, right? So I did not care much about that. Come to find out that I would have been that patient because I have a COMT mutation where morphine does not give me the analgesic effect it's supposed to give me. So those patients, I was actually exposing them to unnecessary pain. Well, I should just have listened to them instead of judging them. This is what we're talking about when we talk about pharmacogenetics. A couple of years ago, I was doing oncology study, mapping of oncology facilities in Nairobi. And while we were there, I met this lady, and she's from Europe, and she was saying, genomics, why are we doing genomics? Genomics is like driving a Lamborghini when a bicycle can work. So I disagreed, and I suggested that most of the models of all the drugs we see are based on Caucasian models. We are not the primary customers of all drugs that are being made. As a result, our core key mutations are not taken into account. So we could expect people to react a particular way from a drug, but we will not because we are different. Africa probably has the most diverse genome, yet we extrapolate studies from the West and other places and try and fit them here. We are using proper science that we know now. But is it what we really need? So now I want a couple of things now as we go towards, what's going on here now? Okay, I'm going to start with that. This is what I was going to talk about, and I'll do it very quickly, very simple. I want to remember what we're going to talk about. These are not dense. They're not going to be dense slides. I want you to realize that Africa is 20%, between 20 and 25% of the Put it on slideshow. Slideshow. There? Yes. Good. So Africa has got about 20 to 25% of the population. Yet, average age is 19.5. Life expectancy about 70 years, so 50 years, right? So remember that, keep that in mind. And then remember, this is the other interesting information to know, that less than 1%, 1.5% of, 1.1% of data from us. Studies that are being done here, clinical studies, are between 3% and less. So when you tell me that a drug works this way, I can follow what you told me because you've done good science, but I can also make sure it's appropriate for me by doing the genetic testing. So if I can do pharmacogenomics, then I understand what genes do you express and what do those genes do, right? So we are totally very underserved. There's a few things happening. We are very diverse as a continent, but there are few efforts that are going out there that are helping with us getting some of this information. So a couple years ago, I was at UHC conference, which is the Universal Healthcare Conference in Mombasa, and apparently they did not include very many pharmacists in there. And I said, without managing how we use our drugs, there's no universal healthcare happening. Because if you don't know which drug you're taking, is it helping or not, you'll be either worse, you will not get better. So secondly, I also realized that if for us to use the right drug, we need pharmacogenomics to understand, is this the drug that works? Just like what our colleague just mentioned. So this was just a silly picture to say that if we do pharmacogenomics, we'll get the right drug, positive outcomes, increase compliance, reduce adverse effects, right? We kind of know what to expect. Right now, we don't know what to expect. When you quote New England Journal of Medicine, a fantastic journal to me, how many Africans, what percent of the staff information in there is African-based? What percent is Kenyan-based? And even in Kenya, how many tribes do we have? How many tribes have different mutations? So when you tell me New England Journal of Medicine, yes, it's good, but how appropriate is it for our populations? So I'm going to go through different mutations that are there that have made a difference, that are prominent, just a few of them, that are prominent among Africans, that will affect the way medications work. So there's DPYD. This one, 5-FU, is a common drug that's used in oncology settings. And you can see it actually, we have a different mutations where that drug could actually cause more problems than you had. And this is where now my issue about UHC, the cost of care. If you get any of these adverse effects, we have to treat it. And if we treat that, we're taking money away from where it's supposed to be. And that's what I meant. My argument about UHC would be better if we have targeted therapies. Going back to the Lamborghini conversation, in the long run, it's expensive initially when you do the genomic testing and you do the genomic sequencing. But down the line, once you know what it is, and plus you will contribute towards a database that can be used to the next generation that comes in. So it's maybe an investment now, but down the line, it actually makes a lot of sense. There's another one there, G6PD. That affects some of the drugs that we use frequently. And I put this here because of antimalarial. It's a very common mutation among Africans, and the antimalarial medications are affected. So when you see the lack of effectiveness or increased adverse effects, there you go. This is something we could have tested. If we had a genomic sequencing for you, we would have actually known. The CYP2D6, again, it's also, the prevalence among Africans is also pretty high, and it affects some of the drugs that we use, from even the pain management, arrhythmia medications, among others. So, food for thought. So this is, I promise you, I wasn't trying to be, it's actually a real gene, MTFH. We used to call it something different, but it affects a lot of what we use. It affects methotrexate, which is a common drug that is used among oncology patients. But if you look at the women and the exposure from HRT to oral contraceptive, the risk of clots, which we know is a big deal with hormonal imbalances among women. So this is a thing that we have to think about and also consider when we do what we need to do. And among others here. So COMT, like I said, I have a mutation of COMT. So if I need to take pain management on myself, I normally suggest we use Dilaudid instead of morphine. Now that helps the cost, because if I'm getting morphine that I don't need, that is not helping, that is cost that we are spending that we shouldn't be spending. So that brings in the targeted. And while we're there, before I move on, I did have somebody very close to me who went to surgery, but we had already done pharmacogenetic testing for her. And when the anesthesiologist saw the report, they reduced the anesthesia by about, they said 40%. So my question was, supposing I hadn't brought the report, what would you have done? He says this is where experience comes in and you have to know how to manage the patient. Now, the time they take, supposing it's not an experienced anesthesiologist, supposing the patient reacts in a different way than you expected, that is why it's important to make sure that you can have, even each one of you should have your pharmacogenomic report so that subsequent care is appropriate and targeted to you specifically. This is now when you start having the machinations of, we know USAID left Kenya. We know that aid is going to be a problem. What do we need to do? We need to start thinking, even what we are doing here, even research, we need to start thinking about return on investment. How can we use whatever comes in as aid to us as a way to invest for the future? And that is why we have to start thinking business whenever we are doing these things. Aid was a thing where we used to use, and by June, you want to make sure you finished 100% of what you got so that you can get a replenishment. Now, the question is, how much did you make? What impact did you have to your communities? Is it sustainable? Because if it's not, it's going to die. And if it dies, the people who are getting the impact from it will not be able to get the impact again. So this was my way of showing that if you don't know what drug you're taking, if you take an anti-malaria that doesn't work, then you spend longer with negative outcomes, you spend longer without going back to work. Per day of not working, how much do you lose as a person? And there's mathematics for it. Of course, it's not exactly a clear science, but it's between $5 and $15 a day. So if you have 100,000 people in Kenya who don't show up, that is how much they're not contributing towards their economy. And that is how the money that you also use for UHC. Because at the end of the day, this issue of silonization doesn't help. Why are we doing pharmacogenomics? How can we improve healthcare? And how do we improve healthcare? How does it improve productivity in the country? How does productivity in the country help us, give us more so that we can be able to move to where we want to move in terms of the economic work output? So I just wanted, this is a picture roughly. So pharmacogenomics will affect the therapy. Therapy will affect the outcomes that you get. Of course, UHC is there as an ROI, return on investment, and ultimately the economy. So we have less people who are staying home for lesser time or unnecessary. We have lesser people staying at home unnecessarily because they got the wrong drug that caused another problem that we have to deal with. Okay, and that is what I had. I hope I made sense. Oh, one more thing. The questions will go back to him. He has more of the answers than I do.
Yes, thank you, Lucas, for that nice presentation. So next, I will call Peter. Peter is an application scientist, I think, with F&S and Illumina, and he will tell us what they are also doing in this space. And just note your questions down. There'll be enough time to ask them. Welcome.
Good afternoon, everyone. Also, another disclaimer, questions will go to the previous presenters. Okay, so yeah, as I've been introduced, my name is Peter Ndiga. I'm a genomics specialist at F&S Scientific. So F&S Scientific is a local company, and we are